uncompensated care policy. We added to the agenda a discussion of denials based on the request of United. I don't see Gary here.
I'm on the phone, Donna.
Oh, okay, great. So, so we've added that to the agenda, and then we're going to begin to look at the factors that that might go into the balanced update based on the most recent information available from Global Insights, et cetera, and other short-term adjustments, including shared savings policy adjustments. And then we're going to discuss potentially avoidable utilization and its possible use, its current use in the demographic adjustment and its possible use going forward for other purposes, particularly in looking at guardrails. So that's a fairly full agenda. It could take up the full time, or it could actually shorten up depending on the level of discussion of each of the items. Although we never quite know whether the discussion will expand or contract, so we'll just have to see. So we were going to start out with the first draft report on uncompensated care policy recommendations, and you have a printout of that in front of you. I know it was emailed to you, and it represents a first draft from the HSCRC staff with some of the comments that have come in from the work group of what we're thinking in terms of taking to the next commission meeting. And we did present some of the information out of this document to you at the last meeting. One of the, if you look at, I want to get to the right page here. I'm page 8, actually, of the uncompensated care document. One of the things that that we'll be discussing is the proposed change in uncompensated care and rates for fiscal 2015. And we have a particular item, which is the reduction for the enrollment in the Medicaid PAC program. We have been evaluating the data, and we did get quite a bit of information back from the hospitals yesterday. So basically, we took all of the claims that were for these enrollees that were non-emergency room and added them up, and then we've sent them out to the hospitals for verification. We got our first batch, or a major batch of verification back in yesterday, and we did see that there were some claims in the data that were paid, and it appears, but we're not really sure yet, and we're still evaluating, that there were some psychiatric claims that might have been paid in the data. So that in addition to emergency room, maybe there were some psychiatric claims, but we're not sure yet, and we will continue to evaluate that. So, assuming that those psychiatric claims were actually paid, the number that we have here that is identified as a decrease for PAC will go down. So that might, from a preliminary look, if the amounts that are showing as potentially paid pan out, that might actually reduce that number back down to my original estimate, closer to my original estimate of 0.8, because it looks like the payments that have been identified are around 15% of the total amount. On the other hand, there could be some errors coming back in from the hospital's identification, and so we'll try to sort that out in the next couple of days. But roughly, I just wanted to say that that number will likely change based on the identification of some payments on that PAC data. So I think actually leading up to page 8 in the analysis is really we've actually covered the content leading all the way up to page 8 in here pretty fully in this group, which is to look at the actual uncompensated care that was in rates in 2014 to determine the impact of the change between the actual bad debts and rates between 13 and 14, which is 0.38%. And then in the last meeting, we also discussed this PAC analysis. On page 5, we've identified some other Medicaid expansion populations that we might want to go back and look at some more as the year shapes up here. And these are expansion populations. When we get the Medicaid enrollment, so we have 232,000 folks enrolled through Medicaid. And we know that 164,000 of them are new populations of enrollees. We don't really know, without getting some information from the state, of the rest of the new enrollment in Medicaid, of how much of that is just normal rotation, because these are gross numbers, not net numbers. So Medicaid, for anybody who works in that area, has a large churn. So you have enrollment and you have disenrollment, and so I don't know what the net numbers are right now in terms of the net increase in the enrollment, and we'll try to get that information updated. I've reached out to Tricia Roddy to ask her to get us the net figures so we can actually see what the net enrollment is. But we do know that these new expansion populations were not previously covered under Medicaid, except in the limited sense for the PAC enrollees. So we do have another 66,000 childless adults that are part of the expansion. They're based on national data, and again, we haven't looked at local data. Their use rates are probably not as high as the PAC enrollees, and according to the national data that's coming out, that this expansion population tends to be a little bit lower use rate than the Medicaid population as a whole, because they may have had access to insurance previously and aren't necessarily at the same poverty levels as the PAC enrollees. So that'll be something that we can start evaluating, and as we move through the year and we look at that enrollment as well as other enrollments, then we can come back at January 1 and say, do we need to make another reduction in rate for uncompensated care based on all of the information that we now have in hand as the year has started and we have this new enrollment information available. Are there any questions or comments about that particular aspect? So I want to move on to talk about where we are with the regression analysis, and we actually did present some information on the regression analysis that we've been conducting at the last meeting, and I know that a number of the hospitals have had a chance to look at look at some of the changes in the proposed regression formula, and the Hospital Association has as well. But as we discussed at the last meeting, there are 4 explanatory variables, and this is starting on page 9 of the document, 4 explanatory variables in the current regression analysis. And when we rerun those variables with this year's data, one of them is not statistically significant, although overall the model the model itself is statistically significant. But our staff focused on developing a new model and evaluated more than 40 variables to develop a 5 statistically significant variable model. And that model does perform better, if you will. It has a higher R-square than the 4-variable model, and it begins to go away from using Medicaid as much in the formula to predict uncompensated care. With Medicaid coverage getting better, that's going to be a more important focus going forward. And so the staff at this point is recommending to move forward to the 5-variable model. We looked at also the option of using 2 years of historic bad debt in the blending. Right now, we blend 50% of the actual experience with 50% of the regression model. The actual experience has been 3 years, but we also did a version where we looked at 2 years of historic experience for blending. And in this draft, we're focused on combining 2 years of spending with the new the 5 statistically significant variable model. Part of the reason for that is that as we go through the next couple years of change, that we are probably going to have to stay in a shorter period of history as we add the expansion populations, and it will be easier to make adjustments to the data so that we can do a regression adjustment next year if we're looking at a bit of a shorter window. And so that's where we have laid out this draft recommendation, and I'd like to just open it up for questions or comments about where we are with those 2 particular issues of moving to the 5-variable model and the 2 years of history to blend with the regression adjustment.
This is Mike Robbins. We've reviewed these new changes. We also looked at some other possible models, like changing the blend from 50-50 to something different. We are supportive of the recommendations that you have before you, with the understanding that the specific PAC adjustment may need to be finalized. In terms of the recommendations you've listed on page 12, that's consistent with where the hospital field is.
Are there other questions or comments?
Donna, so the change in the blending from 3 years to 2 years will be listed here as one of the recommendations that the staff's making. Correct?
Yes, I think we've gotten it in here. I think it's back on, and I think it's also it's on page 12, but I think it's also on 10. Right under the table, it says, similar to the current model that combines the regression with...
Right, 2 years. I see it on page 12. 2 years, I see. It's embedded in there. Okay. Okay, thanks.
I think Shule is asking about the December hospitals. I don't know if we have gotten their data in here yet, and that is something that we actually still have to get in to get in 2 years of actual data. We need to have the actual figures from the December hospitals in the model, because right now their 2-year actuals are actually just 1 year of data, so we need to get those data into the model.
Yeah, and just for those of you who are not familiar with the December hospitals, those are the fiscal years that their fiscal year ends in December.
So Donna, this is Gary. One quick question. I recall some discussion around what constitutes charity care. So it's just if we're here in this space, is there a need to better define charity care, or do you think between you and Mike and everybody, everybody's got, that's really not an issue, and I just misunderstood previous conversations about it?
So anyone else can type in. I don't think there's a problem with the definition of charity care. I think it's been fairly consistent. The classification that hospitals make between charity care and bad debts has inconsistencies. Some hospitals do a more thorough job of classifying charity and bad debt up front, and than others do. So I think
I guess
definitely a classification.
Yeah, is there something that you ought to redefine on how to appropriately, segment it? And if it is, is this the right place? So that I just remember some discussion, and I think since you just mentioned it that way, the difference between uncompensated and charity care is a little bit of a, handled different ways. And if you need to clean that up, then do it. But if there's nothing to it, then okay. I just remember some discussion. We
did have a multiplier on it where we were actually allowing a 20% add-on for charity care. The HSCRC suspended that multiplier last year, and we're recommending to suspend it again, particularly as we're enrolling a lot of the charity population in the expansion, that it would be very muddled trying to have a charity care multiplier and having an expansion to charity types of patients going on at the same time. So we've recommended suspending it until we're finished with the massive expansion that we're undergoing and we have clean data. And then what we've recommended is actually data collection to see what is hitting the write-offs for charity and bad debt, because one of the other concerns that we have is that a lot of the new write-offs might be coming from high deductible plans, and or I would just say not necessarily the definition that you would say of high deductible. It's not the high deductible with quotes on it, but just much higher deductibles that are hitting all of the insurance policies today, and the higher deductibles that are on the outpatient side causing bad debts to rise in the hospitals, and making sure that we know what is actually causing the remaining bad debts. Is it copays and deductibles? Is it continuing uninsured populations of people who aren't covered by ACA, or other people who decided that they didn't want to get covered under ACA, et cetera, and so forth. So, or couldn't afford to get covered under ACA. So I don't want to make it sound like that's an automatic thing, because the ACA policies are still pretty expensive for a lot of uninsured folks. So I think we're interested in getting ongoing information on that, on what's driving bad debts going forward after January 1, and try to collect some data and rejoin it with the initial encounter so that we can see whether it was a write-off on a commercial account or whether it was a write-off of an entire account. And I think, Gary, you brought up the issue of denials, and I wanted to see what you were, I don't know if that fits into the conversation here or that's a different conversation.
That's it's a little different conversation. So, we can, to me, Donna, let's, my suggestion is, close off, the bad debt, charity care recommendation, and then we can talk about denials.
So, I'm not sure we should close off the conversation about that. Now? Okay. I'm not sure we should close off the conversation at this point, because if you're going to make a PAC adjustment, you're using actual charges that the hospitals have been incurring, and if historical patterns continue, a portion of those will be denied. So you're deducting out the full amount of the PAC charges, and we're not going to get paid for the full amount of the PAC charges. They're going to flow through the payment systems, and some of them are going to get denied. I think there needs to be some consideration in that. In addition to, I think, have we built an adjustment in for the contractuals that will result already?
Yeah, I think what we've noted in here is there's two choices. One is we could lower the uncompensated care adjustment, so meaning that we would subtract less out of rates by 6%, because the Medicaid will, if the coverage goes from no pay to Medicaid, there's a 6% reduction on Medicaid, and therefore we would have to lower the impact on rates. The other way that we can do this, which is what we're at least tentatively thinking, is to adjust the PD schedules when we do the annual update on July 1 to reflect higher amount of Medicaid revenue based on the PAC adjustment. So the hospital that is having a PAC adjustment reclassify between self-pay and the payer differential schedule from the annual filing when we do the PD for each hospital on their 2013, 14,
I mean,
15 update.
I would be okay with either way on the contractuals, but when you get to the denial issue, at least related to these PAC charges, a certain percentage of them will be denied. It'll happen. So that, and denials don't get reimbursed. So if you're going to decrease uncompensated care by the amount of the PAC charges, you have to adjust them for some sort of anticipated rate of non-payment related to denials.
Are there other comments on that issue? Do you know what do we have any information on the Medicaid denial rate?
Yeah,
the MCO denial rate, because it's all the PAC enrollees are being enrolled at MCOs. Is that correct, right. Dolly?
Yeah, the MCO denial rate's a lot higher than all the other denial rates. So we've done some calculations back at the hospital, and 10% or so is what we're coming in at.
One of the things is that the emergency room is already covered, so that's not a new coverage under these PAC enrollees. So I know that's an area that has fairly high denials, but in order to really assess a denial rate, we would have to pull the ER claims out because they're already being paid for, and their whatever denials are involved.
Yeah, the ER denial rate's off the chart when it comes to the MCO, at least in my organizations. It's in the 30% range. I'm talking about the non-ER denial rate.
I guess the question is, how would we get enough information to make any kind of a
I mean, I think the dollars we're talking about are significant.
I totally agree with that. They are significant.
Yeah, on an ongoing basis, I think as we're entering into a stage where hospitals are on global budgets, and there should be no volume incentive for bringing volumes into the hospitals that aren't medically justified, it may be worthy to, as we're collecting bad debt data, to collect denial data so we can understand what care is getting, what care is getting bumped, if you will, on the denial front.
Yeah, and Donna, I don't think we want to. I hope we're not finished with the uncompensated care yet, because I don't want to drift into the denial conversation. But it is. I think it's important for folks to know that denial is largely around medical necessity, but it's in the eyes of. It changes depending upon who is assessing that. The clinician at the scene is one conversation. A retrospective look is another conversation. So this denial issue is not immaterial, and I'm glad it's on the agenda for discussion at some point. But I think data is needed, obviously, to do something. But my other comment about the PAC would be, and I think you and I had a recent conversation about this, and that is, while this money is coming out of rates, was it ever in rates? Do we know for sure that the regression that hospitals have been living with, do they in fact reflect what we're getting ready to take out as actual, which is based upon 1 year's experience of actual? Well, we all know that hospitals don't get passed through their actual experience. And so how do we make sure that we don't overstate or understate this PAC adjustment? I think intellectually this needs to happen. And I'm just sensitive to an aggressive action prospectively on well-intentioned and good data, but maybe not a complete picture, because we don't know what we don't know.
Well, once we get the verification back, we will have a sense of what was actually paid, and we do know that what wasn't paid is actually built into the rates, because we're building it in. We just made a 0.38, and we know statewide that it's built in. It's clearly built in statewide into the rates, and it's been built in. I'm
not talking about statewide. I'm talking about individual hospitals. Getting this correct. Mm-hmm. It's easier to get the whole state correct than it is to get 46 acute care hospitals correct, mm-hmm, one at a time. But just one last comment I could make, and it's just a small mechanical thing, and one that I'd ask that we study a little bit more, and it's a concern that we noted that, and maybe it's the words here are in these variables, Medicaid, and then there's a variable self-pay, charity. But there's this whole category of patients under Medicaid pending that sometimes hospitals report them as Medicaid, sometimes hospitals report them as self-pay, and there's a difference there and not been consistency about that reporting, but we're using data. So I would just ask that we take some time and make sure we have this done consistently, that we push it all in Medicaid, push it into self-pay, but get this right. And that's my only mechanical or technical request. I'm done.
Yeah, I don't think that we can, unless Julie knows of some pending status to get from the historical data. I don't think there's any way that we can make a perfect adjustment for that. And so the balanced way is, do you include Medicaid like we did in the past regression analysis? And we know that that creates very large residual values that have of certain hospitals consistently getting more than their bad debt or less than their bad debt. Or do you take that data and recognize that there are some possible weaknesses in the classification of the data that's imperfect, but that it produces a better result in terms of the distribution of the uncompensated care pool and the lower residual value. So for a number of the hospitals. So I think that's really the issue of balance. I do think it's possible to look at the PAC data. Yeah. I think we could potentially relook at the PAC data as a regression element. But overall, I think what we see from looking at the details is that the new model is better than the previous model, and that it has.
But Donna, it's based upon a inconsistent, known data flaw. That where Medicaid is, in some hospitals, the Medicaid, they've included Medicaid pending. Other hospitals include it in self-pay because you just don't know it's pending. And I'm just saying you may have a good answer right now, and we all like that. I'm just pointing out that, and I don't even know what the answer, how this results. I just know there is a bolus of patients that don't have a consistent home that right now are giving us a good answer. And I just think that could be happenstance. That's my point. And I'd rather us, historically, a decision was made. It goes in Medicaid, or it goes in the self-pay. And I think we just need to be consistent. Once again, my point is an aggregate answer that gives us little residual is good, but we got to make sure that we're still focused on the individual hospitals.
Can I
So,
anyway. Comment? Yeah, I agree with Donna. It's the residual, the fit is actually better at the hospital level, not at the aggregate level. And we can look at, in the last year, I think we collected Medicaid pending as a separate variable. We can take a look at it, but that variable itself has more problems than our expected payer collection. It's just we are looking at the goodness of the fit. Even if there are impurities or data problems with individual hospitals and the variables, what the model is showing us overall and at the hospital level, it's much better fit than the one that we had previously. But we'll explore it a little bit more on it.
Yeah, this is Mike. Just a couple of things I'd also point out is in your last recommendation, you do indicate that this is really a recommendation just for fiscal year 15, that some of the issues that we're addressing here that might require a fair amount of additional data gathering or data analysis can be addressed in an update to this policy for fiscal year 2016. So while I would commit to quickly trying to get a sense for the issue that Dave raised regarding denials and the impact of that on the uncompensated care numbers here, the adjustment, I do think that some of the issues that we're raising, even at an individual hospital basis, let alone statewide, are in the, if you will, hundredths of a percent potentially. And so I would, at least at this stage, and again, I understand that what I'm hearing from my own members, argue that while we can make every attempt to perfect this, we still need to get something before the commissioners fairly soon, with the understanding that it's just for the next year. As we gather more data, there may be the opportunity to adjust these variables even further, let alone the fact, as you've already suggested, that other things are going to be happening with actual uncompensated care that will need to be addressed in the future as we understand more about the other populations that are getting coverage beyond the PAC population.
I agree. We have to get something in front. I do think there needs to be some consideration for how much we're actually going to collect associated with these charges. And we know it's not 100%. We know we have the contractual. It sounds like that's in the works as far as, and there's going to be some level of denials. We're not going to collect 100% of what the charges are. So we know the wrong answer is assuming that we'll collect everything.
Right. And what I've suggested, Dave, is I will commit today to reach out to hospitals, see what data we can quickly get on the denials issue, and see what we can quickly share with the commission so that we can try to get that represented in the final policy.
And the other thing that we can do is, if we look at the denial percentage, the other thing that we can do is we have the other adult population by zip code that Medicaid has just enrolled, so that's the 50-some thousand enrollees. And we can overlay those zip codes with the market share analysis on the same hospitals where there might be some denials, but there's also some likely improvement in collections from these other 56,000 enrollees that we haven't collected yet, so that we can weigh that as a potential factor in our thought process to say, okay, well, maybe we won't consider these denials, but we're not yet addressing these 56,000 enrollees that we have distributed based on the zip codes, just so we can think about it together.
If they all said, I'm fine with that.
But so let's take a look at that, because Medicaid did actually send us the enrollment by zip code, and I think that'll be very helpful for us to help consider the potential impact of the denial.
I'd like to just say something that I appreciate that people have been living under the system so far. But what I'm most concerned about is that as we move to this new world of global budgets, that the incentives are right, and the whole landscape has shifted. Let me make sure I understand the uncompensated care policy, because I totally agree that it's easier to set the rate at the state level than if for individual hospitals, and it's the individual hospitals where the incentives are most at play, and that I'm most, more concerned about. And so you set a pool statewide, and then prospectively put into each hospital's rates what your regression analysis says. 50-50.
Actually, the hospital rates are all the same. So every hospital has the same amount of bad debts in its rates. And so every hospital under this recommendation, which will be revised, would have 6.1%. Let's see, what is that on page? 6.16%. Every single hospital would have 6.16% in rate. So that policy was put in place so that we wouldn't have some hospitals that had their charges jacked way up because of uncompensated care, and then the payers would try to avoid them because they were taking care of a lot of poor people. So it spread equally across the state. Then the part that you said about the regression formula, 50% regression, 50% actual historic bad debts combined to create a value for each hospital of what they're going to get funded in their rates, or what funding they'll have to provide. So if their bad debts are above 6.16, the predicted bad debts based on that formula are above 6.16, they'll take money out of the uncompensated care pool. If they're lower than 6.16, they'll pay money into the uncompensated care pool.
But this is all prospective, and if their uncompensated care reality for this year is different than what you're predicted, there's no settle-up.
That's correct. And it'll come into the formula on a prospective basis for the following year
at a 50-50. Is that where the 50 historical?
Right, but it's not just 1 year's worth of bad debt experience. We've been using 3 years of bad debt experience on the blending, and we're saying go to 2 years now because of all the changes going on.
Okay, so in other policies like outlier policies, there are often pools where people can charge their actuals to the pool, and you don't have this risk of your prospectively setting something that may not actually pan out. And I understand that if you have that, there are incentives for everybody to charge all of their bad debt to the pool.
And actually not pursue collections.
And not pursue collections. But I don't know if, I'm concerned that the real wild card this year is the undocumented that we know almost nothing about, and there's so many changes to the Medicaid, the expansion, the people coming in, pent-up demand for the new enrollees, that any regression based on historical data is going to be inaccurate for this first couple of years. And so I don't know if it makes any sense to consider some other partial, not fully prospective system.
We already have a not fully prospective system because we have 50% that's based on actual, and I think it would be really difficult to allow actual to be charged because of collection policies, and also just there are spikes in hospital write-offs and write-off policies. we've had a lot of hospitals with computer conversions this year, and I don't want to tell you how many problems we have had here at the agency with problems from people converting to, I shouldn't name vendor names, but but we've had quite a few problems, and my years of experience tells me there's some collection problems that go along with those conversion problems, and we don't really want. There are some health systems in here who've done a really good job on collections, and I don't think the Commission would be very favorable toward letting other hospitals who don't try or do as good of a job to just automatically dip in. But we have taken steps in this new formula to help reduce the problem of the undocumented immigrants by looking at the Medicaid enrollment and actually taking Medicaid off as a variable helps us identify undocumented immigrants better, because they're not covered and they're not being predicted as part of the formula. So we've actually taken 2 steps to try to give more weight to people who might not be covered going forward.
Okay, I think I understand it a little better. It's a pretty complicated formula, but by blending historic, if your experience at an individual hospital is higher than average, you get back some of that in future years by that blending.
Right, and then as we get actual data in the door for coverage, then there will be a smaller and smaller slice of self-pay, and that smaller slice will get weighted more heavily in the regression formula going forward, because it becomes smaller and smaller as the Medicaid enrollment expands to take over chunks of that self-pay. So what's left in self-pay will be more and more people who can't get coverage, or people who choose not to get coverage.
Okay, I think I have my questions answered. Thank you.
Whichever order. We'll go in this order.
Well, I'm quick. Isn't also included in self-pay calculations the amount of money that an individual may have who has adequate insurance but is elected perhaps a high deductible or whatever reason has a significant copay, and if they for some reason renege on that commitment, doesn't that become part of the self-pay?
It isn't in our data. In our data, self-pay is a classification of someone who doesn't have insurance coverage. So the deductible and copay is in our data shows up under Blue Cross or United or whatever the commercial payer is. And so in order for us to see what those enrollees are not paying, we're actually recommending that we collect some write-off data so that we can go back and say, hey, guess what? Blue Cross enrollees didn't pay, or United enrollees didn't pay, or some other commercial insurance enrollees didn't pay, or self-funded plan XYZ enrollees didn't pay. So we will be able to do that when we collect write-off data on an ongoing basis.
So, but aren't the hospitals reporting that perhaps under uncompensated care?
Yes, it's either a bad debt or a charity allowance.
Okay.
So today it's either bad debt or charity.
Thank you.
Okay, yeah, and I have the perfect follow-up to that, too. The other wrinkle is with the Affordable Care Act, between the Medicaid expansion population and to under 50% of the federal poverty level, there is governmental support for not only premiums but also copays and deductibles. And, you know, I was the one who raised the issue in terms of be careful as to when failed collections or inadequate attempts to collect sort of transition into the bad debt. And I think it would behoove the Commission to monitor when the systems get in place for the hospitals to be able to receive a share of the premium support, of deductible support and copay support from the government. I'm not sure the mechanism is in there yet to do that. And when they should, in fact, be able to get that money, then at least part of the copay and the deductible from the government up to the 250% of the federal poverty level. And that's going to mean not only do you have to know who's insuring that percentage of the population, but also in terms of what the income is on some of these people that are showing up as uncompensated or uncollectible debt because they have high deductibles and copays, when in reality some of that deductible and copay is supposedly subsidized by the government under the Affordable Care Act.
Now, this may be my incorrect understanding, and so you may have a better understanding, but I thought that the policies were automatically adjusted. And John, maybe you know the answer to this, or maybe not, and you can help us out with this, but I thought the policy deductibles were automatically adjusted for the income level so that when a person showed up, that subsidy, in effect, already kicked in at the point of service. Similar to the way it does on say the Medicare Part D, where if somebody has qualified for low income, then that their copay for a drug is immediately put in place at the pharmacy. You don't have to wait. The pharmacy doesn't have to wait to get the money later. But I'm not 100% sure on that. I thought it was automatically adjusted. But we'll check into that, but I did think it was automatically adjusted.
I have no idea how administratively hospitals would be able to even pursue that.
So that's why I think it's automatically adjusted.
Operationally, it would be impossible.
I would just check on that because there's so much of the back end of the Affordable Care Act that is not yet figured out. So that
I did read that part of it, but and I understood from looking at those policy descriptions that it was automatically adjusted, but I could be wrong based on the income level.
Hey, Donna, just an off-the-wall, out-of-left-field comment that was just dawned on me. Hospitals spend a lot of money trying to get payment where there's a possibility of payment, trying to get enrolled in Medicaid, and it's not inexpensive. So I'm sitting here listening to this comment and thinking, what would be less expensive? Have the hospitals gear up a machinery to pursue some reimbursement here, or just let it go through rates? And I'm not advocating one or the other, but at some point, the cost of trying to get things done can overwhelm the benefit and the complexity, making things more complex. And I'm not advocating one way or the other, but it's a good thing to keep in mind once in a while how much effort are we taking, and not to be philosophical, but out of clinical care and putting it in the back office to get some things done.
Yeah, and it was only a year ago the hospital industry was getting criticized for pursuing collections too aggressively.
Correct. We were. And we were spending a lot of money. We were spending a lot of money to be criticized.
Don, I just wanted to comment here when you got onto the issue of trying to get more data on the MCO denials. And I know we've got the urgency of figuring out the uncompensated care factor here for the hospitals, but I have to say that I know from the physician perspective with the MCOs, the denial rate, especially in the emergency departments, is enormously high, 40, 50%, I mean, enormously high. So if you're collecting data on denials, I think as we look ahead, we need to put that into the mix.
Okay, I think that's a good recommendation, and I don't know if it quite fits here, but we could add it to the recommendation. It's not something that we reimburse under our uncompensated care policy, but it's something that we should try to understand as we move forward.
It could be a lever one day in helping meet the waiver requirements, because if you can reduce the denials, you can reduce the charges.
So in terms of leaving this section, I think where we are in terms of leaving the section that we're on is that we are amenable to looking a little bit more at the PAC calculation. We have to get confirmation on the PAC calculation. Mike will try to get some additional information on the denial percentage exclusive of emergency room for MCOs, the Medicaid MCOs in particular, and we'll try to take a look at the impact or work with folks who want to take a look at the impact of the PAC percentage on the calculations, and see what we come up with. So I think that does get us to the recommendation page. Just so Mike Robbins jumped forward to the recommendation page a few times, the draft recommendations on page 12, and number 1 being to reduce the uncompensated care provision from 6.86 to 6.16. That will be modified to reflect whatever we find out about what's actually being paid out of the PAC. And that we continue to monitor uncompensated care levels with the new enrollment that's coming in. And if warranted, we could make a reduction on January 1, but we should be planning on another reduction, hopefully. Hopefully it's not mitigated by more increases in deductibles like we saw this year, but hopefully another reduction on July of 16, if not January 1. And again, to change the regression analysis to the 5-variable model, blending the regression results with 2 years of historical data to determine the contributions to the pool or withdrawals from the pool, and with the caveat that we've just talked about, that we will go back and take a look at the impact of PAC on that calculation. That the charity care multiplier be suspended indefinitely and not reinstituted in 2015 rates, and we'll see if it comes into play at some point in the future, but not now. That data be collected on write-offs to help guide the development of future policy and to improve the regression models that we're able to build in the future, and that recognizing that this is a 1-year model, it won't work next year. We're going to have to make additional adjustments to the model to reflect the large PAC and other Medicaid enrollment that occurs during the current year, and that will affect the model next year. So I think we have at least one additional recommendation to collect denial data, so that we can have more information on denials. Are there additional comments or questions about those recommendations?
This may be just reacting to my own failure to pick up the different parts of recommendation 3, but it might be easier to see them if they were listed as 3A, B, and C, you know, and kind of it would be clearer then.
Okay.
And I did some quick checking, and it does appear that the government subsidy to offset deductibles and copays are automatically incorporated into the policy that the person has if they qualify for a government subsidy. So there shouldn't be a problem on the hospital.
Oh, great. So you got onto the internet very quickly there. You technology savvy person. So excellent. That was my understanding from having spent more time reading those policies than I wanted to, but so that's good. so we won't need to circle back on that particular issue.
Donna, I similarly looked up just to try to find out, and I did find something that confirmed that it is supposed to be automatic. But the qualifier I would say is that the intention is for it to be automatic. The reality is it may not be automatic. There may be a lot of complexity to, if it's supposed to happen, what's the guarantee that it will happen? That's my only concern. So I wouldn't say
it happens in the enrollment process. So when you push the button and you're low income, it pushes you to the policy that is for the income level that you have, like the federal Part D policy. So you get pushed to the right policy based on your income level at the get-go. And there really isn't an option B. Now, that's not to say that there's not screw-ups in the process, but it's not an option B thing. So if your income level is the right level to get a subsidy, then it's going to push you into the deductible that you're supposed to get. Now, I guess the health plan could screw up the execution of that, but at least the process that at least is outlined in the law is, at least to me, fairly clear that you should end up with a policy that is appropriate for the income level that you have with the right level of deductibles.
And why in the world would you think that there would be any snags in the enrollment process?
That's right. We've hit the max. We've maxed out on the number of complications that can happen, so we've got to assume going forward. But I just meant, yeah, the intention, I think, is for it to happen automatically. I don't know how the complexity might complicate things, but I just know because of the track record with all these things popping up, I just think we may want to sort of keep that book, that chapter open, that it may not play out the way that it's supposed to play out.
Well, that is definitely one reason why we're not chomping at the bit to declare victory on bad debt reduction for the new enrollment from the ACA. Not only do we not know exactly how their deductibles are going to come out, but also they have to pay the first premium before they get covered. So we might have 60,000 enrolled, but I don't know what the count is today, but not all of the enrolled folks have actually paid their first premium, so they're not actually covered. And I guess one of the complaint factors I've been hearing on the buzz, too, is if somebody doesn't pay their next premium after their first one, they could go to the hospital and present their card, and in the end, the hospital won't get paid for the service because the person didn't actually pay their second premium. So there's a lot of perils with bad debts with the new enrollment, and we're not ready to declare victory on uncompensated care yet on that enrollment, whereas we are prepared to declare victory on the Medicaid enrollment because we have more surety that that's actually going to get paid. So, other questions or comments? So we can move on to the next topic, which is to just begin to begin the discussion of as we work our way through the balanced update of what are the factors that we would prepare to present to the Commission at the next meeting. And there are two sheets of paper in front of you, and I probably can click them forward in the PowerPoint.
I'm just looking at the agenda. I just want to make sure, because Gary's on the phone, did we address, Gary, your concerns about denials?
Oh, you're right.
No, I get, and thanks, Mike, for bringing it up. I guess, my question, Donna, is when a payer denies a hospital claim or a piece of it for lack of medical necessity, for example, my question is, how does that get adjusted in the revenue models for the hospitals, or how does that take in consideration when we develop, the TPR or GBR budgets? how is that reported and how is that calculated?
The denials, Gary, are supposed to be, a reduction to the gross revenue that they report. So Dennis is back there. Dennis, do you want to comment on that? Dennis Phelps is our head of audit and compliance.
So is that a separate line item that comes in, gross revenue less? I want to know that there is, because that should not be recoverable revenue. So we're in this, new design, so I'm just trying to reconfirm how that process is done.
Yeah, that's a deduction from revenue. It's a separate line item. One reports to us. Denials for medical necessity or a reduction of patient revenue.
Gary, maybe I can ask this question another way. Are you concerned that if there is a denial that reduces a hospital's revenue, that within a global budget they would somehow then offset that with an increase in rates to offset that? Is that what you're suggesting?
Yeah, again, Mike, it's trying to, I've never really kind of been through that part of it. But yeah, as a hospital adjusts its charge master to recover against either lower utilization or higher utilization, my question is, as they do those adjustments to, adjust the daily price, is it, again, that medical necessity reduction should not go into the, charge master adjustment. So I'm trying to figure out how that is done, or, and again, as the global budgets are set, that, those denials are not picked up, in revenue going forward.
My understanding historically, and you all can correct me if I'm wrong, but the gross revenue is the charges to all patients, whether denied or not. There was a period of time when some hospitals started reversing their denials out of charges, but then the commission made clear rules that if you had a denied patient, you had to show it in your gross charges and as a deduction. So as a result, the gross charges include the denials. So if the service is denied, there's no ability, as long as it's included in gross charges, to increase charges to other payers to collect that for that volume, because it's part of gross charges. It's not a deduction when you figure out what your revenue cap is. The revenue cap is based on gross charges.
That's right.
So why would it, okay, Donna, then, to me, maybe I misunderstood you, but why should we be paying for stuff that's not medically necessary? Maybe I misunderstood.
It's not paid for. It's in gross charges, but it's not paid for. So if you don't pay for it, there's no money coming in the door, even if it's in gross charges.
It counts against the global budget, but it's written off. Hospital winds up eating that. They don't get anything for it. Doesn't go in uncompensated care. It's a separate line item.
Gary, this is Dave Kreising. My concern is the opposite. If you had a global budget set of, say, $100 million, you have $2 million in denials, essentially you're saying the hospital should collect $98 million, everything else constant. If denials go to $3 million, you're not getting your $98 million global budget, you're getting $97 million. So, and likewise, if denials drop, I'm okay with keeping the $98 million and not getting $99 million if denials drop. My concern is the level of denials in the baseline should be the level of denials that you're held to, and anything above or below that should be compensated for in some way.
I have to disagree. I think hospitals work. First of all, Gary, it's Hank Franey. And I think your issue, I think I understand your issue, and I think it becomes a problem, not to be flippant here, but I think it only becomes a problem if denials stop. So if you would stop denying everything, then I would understand your issue. But I think history has been pretty consistent about denial levels. Hospitals argue and spend a lot of money trying to prove that medical necessity exists. I don't see that, and I think hospitals believe that care, we're paying for it, we think it should be reimbursed. So I think it only becomes an issue if all of a sudden denials stop, and then we should probably have a conversation about that. And I'm not sure when that will happen, but I think Gary, I do understand your point, and I think that is where there could be another conversation, but we're a ways away.
Hank, there's a flip side of that. As denials go up, you're getting less in your global budget.
Yep, I agree. I worry about that too. It does fluctuate a little bit.
But we're talking about medical necessity.
You are, but if you say $98 million is what you need to run a hospital, and you're getting $97 million, you still need $98 million to run the hospital. You might have provided an extra $1 million of unnecessary care, but you're not getting paid for it.
Now, that's another issue, whether everybody should pay for unnecessary care. That's what we're going to get into shortly.
So Gary, is your question answered?
I don't think so, but it's interesting discussion. I'm still trying to reconcile it in my mind about, again, it kind of bleeds over again into guardrails and what's the appropriate level of care, So, I think, Donna, is something that I'm going to continue to ponder as we think about how this thing moves forward. Obviously, I'm not sure I'm comfortable as one payer who wants to be aggressive because that's where our customer base, and another payer who doesn't want to be aggressive on, reimbursement of appropriate care. I'm not sure United wants to be in the same position as everybody except for, I think we all agree that, paying for appropriate care is the right thing to do and not paying for it when it's not appropriate. But I'm not, so I think I'm still confused on how this whole process works. But,
maybe we should put it into a little example chart and share it back with the group so it'll be clearer. So,
that might be helpful.
So that folks can understand that.
Gary, but the one thing you do need to understand is that, you have been making denials in the past, and that level of denials is included in those gross charges. The hospitals provided those services, incurred the cost, and they haven't been paid. If in the future now that you don't deny those charges, they will incur the cost, and they should be paid for those types of services. I'm not sure what your problem is. I do agree with Hank that if you stop denying, they will generate some additional revenue, or if the denials go up, they will be, according to David, receiving less revenue. So that might be something that we talk about in the future, but at this point in time, I'm not sure that's something that needs to be addressed.
Okay.
So we'll get a chart back, and then we'll also add a collection, an information collection on it to the recommendations. So now that we got past that issue, now we can move on to that's good. Move on to the balanced update, and you have 2 pages of that will be part of this discussion. One says discussion of balanced update, and the other is balanced update model for Maryland residents to work through the discussion. And then Jerry's going to walk us through this with Julie and I piping in on a couple things.
Thank you, Donna. The first page, as Donna pointed out, is a discussion of the balanced budget updates. For over these last months, we have been working on developing global budgets for hospitals. We now have a significant amount of the revenue in this state under some type of a global budget or a capitation type of system. That changes the way we now will look at how we provide an update to hospitals. In the past, the labor test was always the change in the amount per case, and that's what we were concerned with. So those were the types of things we considered. The types of things we considered in the past was the impact of inflation on each hospital, and then what that hospital could do to deal with those with the changes in the expenses, given the fact that there was no cap on volume growth during that time. We have now, as I said, got most of these hospitals under a global budget, so now we do have some control over the total expenditures of the hospital over the next year. Because of that, we are looking at things slightly different than we have in the past. During our negotiations with the hospitals, we've had to try to tell them, give them an indication of how we would be treating and how we would be adjusting the global budgets in the future. And one of the things that hospitals have talked to us about is providing them an amount that was relatively equal to what they saw as increases in input prices. And so one of the things that we're starting out with, and this is one of the things we've used every year, is what Global Insights is projecting as the inflation of healthcare cost hospital expenditures over the next fiscal year. And so these are all Global Insights is normally the numbers that Medicare relies on when it sets its updates for their prospective payment system. So the most current number that we have available from Global Insights, estimating what inflation will be for the next year, is 2.4%, and that's our starting point for all these adjustments. All hospitals, that will be our starting point. The next piece, though, is what will be how we will be adjusting rates based on changes in shared services, shared savings, and this past year, hospitals' rates were reduced by approximately 0.2%, and that was equal to 0.3% of inpatient revenue. Next year, we're going to be adjusting that number to 0.4%, and that will be an additional 0.2% offset. So we need to consider that when looking at the global budget. The next adjustment for those hospitals on global budget will be how much we allow for volume. And at least at this point, I believe the demographic, the adjustment for population change based on demographics and age adjusted, and providing hospitals 50% of that, I believe, is approximately 0.8% at this time.
That's an example, so obviously it will depend on how many hospitals we have under global budgets and what their volume growth will be.
And also that the 0.8 includes a crude estimate for some of the AMC issues in terms of the categorical exclusions, of making sure that we provide for any volume that's outside of the demographic adjustment, but inside the global budget model. So there was a I'll call it a crude estimate, adding on to the basic number that was there. But that was an example, and so we'll need to update that with an actual figure.
So that's the starting point for the global budget. Hospitals that are on global budgets and TPR, total patient revenue adjustments. The other non-global revenue, okay, that still are under the Medicare waiver. Again, we start with Global Insights, but now these hospitals don't have as much incentive to reduce utilization as other hospitals. So we're going to provide two adjustments to those. The first one is a productivity adjustment, and that's 0.4%. The second adjustment is an adjustment based on expected reductions because of the ACA. That's another 0.3%. So we would be reducing their adjustments. They would be offsetting their inflation by a 0.7%. They would also, though, would be provided the offset for the incremental share savings adjustment. So for those hospitals, the amount would be slightly different. We will take further steps to put some limits on the amount of volume increases that hospitals that are not under the global budget will be receiving, and we'll talk about that when we go through the next sheet. There are a few hospitals that are not under the waiver, but they are under our jurisdiction, and some of those hospitals we are currently looking at what updates Medicare may be providing to their hospitals on the PPS system. And the most current number that we have for psych hospitals is 2.7% for inflation, with a 0.3% offset for productivity and a 0.2% offset for under the Affordable Care Act. That would result in a 2.2% increase overall for those hospitals. Now, these hospitals here in Maryland, the psych hospitals, they are not the Medicare and Medicaid patients. They are not paid commission-approved rates. Medicare and Medicaid, they are paid based on the prospective payment system for psych for the Medicare population. Medicaid, at least at this point in time, in the past, they were providing hospitals 84% of our current approved charges. For this past year, they've changed that to 94% of the current charges, and they've removed some of the other payments that they were making to hospitals in the past. There are a few other hospitals, such as Mount Washington Pediatric Hospital, and we'll be deciding what in the future what update that will be provided when we get some additional information in. But the bulk of the hospitals will be covered either under 1 or 2 here. We carry that over then to how we expect that to impact hospitals in this next year. That's the next page. I'll bring that up.
Yeah, and I think, we did go through this in a fair amount of detail last time, so maybe you can focus just on where we would be inserting the numbers out of this analysis.
So what we've tried to do then is turn around, and as Donna pointed out, we went through this model last time in some detail, and we're trying to populate this number now with more actual data as we go along. And as you can see, we still have an estimate of the revenues under the global budget at 80%. I do believe that we may wind up with more than that when we're done. And so those hospitals would receive the 2.4% increase for inflation. The hospitals, again, that are not under global budget, they would receive the 2.4 less the 0.7% for productivity and ACA. And so they would receive a 1.7% increase. Overall, we would be providing hospitals approximately 2.26% for inflation for the year. The second piece then is what will we allow hospitals for volume, and the global hospitals would receive an amount based on this demographic adjustment, and our estimate is 0.8% at this time, and that may be fairly close to the number that we wind up with in the end. The other hospitals that are there, they would be allowed an increase in their volume. We put a cap on the volume change for these hospitals that would be equal to 2.4%, so their volume could grow 2.4%, and they would receive only 50% of that change, so they would receive 50 cents on the dollar. So the marginal cost we're allowing the hospitals that we're going to pay for is 50% of the cost associated with that volume change.
And that number is actually between 1 and 1.2, but we just used the maximum amount here for illustrative purpose.
So then the total amount that we might be providing in the way of volume over this next year would be estimated at 0.88%. For those hospitals that are going on the global budget, we are also providing them with some additional dollars to help them defray the cost of the infrastructure that they're going to need to put in place to work on these global work under these global budgets and to provide health care in the most proper way possible. We also have to take into consideration other things that are going to occur outside of these global budgets and outside of these adjustments that we're currently making. One of the things that we're going to have to consider is additional costs associated with providing hospital money for capital needs over the next few years. And for most capital, there's a provision already included in the hospital's rates to cover the cost of ongoing capital. But when hospitals undergo large capital projects, there are times when they need some additional money for capital. One of the times is coming up in this next fiscal year, and Holy Cross in the past was provided a certificate of need to open a new facility up in Germantown, Maryland. That facility will be financed some way or another, so and the dollars associated with that new facility, okay, will be counted under the new global waiver test. So somehow we have to account for that additional money. Some of that money will be coming out of other hospitals in the area, okay, as part of a volume adjustment to them, but not all those dollars can be taken out of those hospitals at 100%. So we're taking only a certain portion out of those hospitals. Donna, if you want to comment on that a little more.
I think what the .41 here is 70% of the revenue of the Germantown Hospital, recognizing that one hospital will have a prospective adjustment, meaning Holy Cross, because they were the applicant on the CON. Other hospitals would run behind in terms of their adjustment based on their actual market share shifts in that area, and for that, at best, the adjustment would be 50%, because we were proposing to make the variable cost adjustment at a 50% level. But we increased the factor to 70% to account for the fact that we're going to be running behind on the non-applicant hospitals. We're not going to do a prospective adjustment. And it's not 100% clear that all of the volumes will actually come from other hospitals. There may be some new outpatient volumes, for example, in the area that will materialize based on additional supply as opposed to transfer of market share.
And just a quick question, that also would reflect the delayed opening, that they're not starting on July 1 in terms of
correct. So that is based on the fiscal year revenue estimate of $80 million that was provided by the hospital, reflecting their opening date in the fall.
And these are adjustments that we're going to have to continue to make into the future as hospitals are filing applications currently to for major capital projects with the Maryland Healthcare Commission. We will be working with them on trying to revise how we provide hospitals money for capital in the future based on this global budgets in the future. So that will be something that we're going to have to consider each year, and the adjustment will probably be different each year depending on what has been approved.
And we're going to take back up that discussion of capital once we get past the update. So it's not just going to be discussed between HSCRC and MHCC, but we're going to come back with the payment work group and discuss that some more too.
Since all of hospital expenditures come under these global budgets, then we have to also look at, and under the waiver test, we have to look at also other changes that will occur in the system. And one of those adjustments we've been discussing, that uncompensated care is increasing over this past year by about 0.38%. We will be adjusting for that. We also have set aside some money that we say are for unforeseen adjustments, and hospitals come in throughout the year for increases to their rates, and possibly for their increases to their to their global budgets for things that are beyond their control, which we feel it's reasonable to adjust for. So we're setting some money aside for that purpose if that occurs. The other adjustment, it says here, we're reversing the shared savings from the past year. So this past year, we reduced hospitals' rates by 0.2%. We're going to add that back. You'll see where it comes down in the future, though, as we go down that page. So there's a 0.2% add back. So the total increases to the hospitals is about 4.86%. There are some other adjustments, though, that we will be providing that will lower rates. And one of those is, again, the uncompensated care reduction that we've been addressing here. And that amount currently is 1.02%. There will be a reduction.
It'll probably turn to 0.8% or maybe a little bit higher based on the collections. If the collections that we're seeing pan out, then it might be closer to 0.8. The net. The net 1.02 is net of 6% payer differential already for Medicaid, but if we have these other collections out there, we may need to reduce that further.
And then the last adjustment here is, again, the shared savings for the upcoming year, and that's scheduled to increase from 0.2% offset to a 0.4% offset. Has an impact of approximately 0.2% for that year. Therefore, the total growth in revenue we're estimating for this year, based on these updates, would be about 3.4%. And if you look at that on a per capita basis, that will provide us a growth rate of about 2.68% for this upcoming year, which is within the limits of our overall test, which is 3.78.
3.58.
3.58, I'm sorry. 3.58 for the year. So we believe the update of 2.4% coupled with all the other adjustments that we're making here will help us to achieve our goals under this new waiver test. And that's what we're trying to do is get, we're trying to get from point A to point B by negotiating these global budgets. This is to get us from point B to point C to take care of us for the next year. There's a lot of other discussions that are going to have to occur after this. So most of these things are going to be in effect for 1 year and 1 year only. And there might be some major changes over the next year depending on this group and what this group decides. One of the things that I believe we really do need to look at is how we're going to make adjustments for changes in market share, and that could be very important and very integral to this. So this is to get us through this next fiscal year.
And Jerry, this is John. This talks completely about the overall 3.58 all payer cap, but in addition, we do have the Medicare test, and I know we don't address it here, and the numbers fall within reason, but that's something that we would certainly recommend that within the write-up, we definitely address the Medicare piece of this and whatever safeguards we need to ensure that we achieve that target also.
Yeah, I think as far as the current actuarial projections, these would drive a number that would be inside the actuarial projections. If we keep the 2% difference factor in play, that this would fall inside that. The big question is, will the actuarial projections obtain? Will we really have a 1.7% increase in Medicare? Will it be lower? If we look, and we've been looking at the MedPAC reports and the federal reports for the growth last year. So the actual per capita growth for 12 was 0.4%. And I don't know, we don't have 13 numbers yet, but hopefully we would be able to get some 13 preliminary numbers soon to see what happened in 13. Jerry's been looking at the 14 and 15 projections, and one of the big issues up in the air is what's going to happen with DISH. DISH takes out, according to the MedPAC reports, takes out 2% in 15 of the Medicare numbers. But in theory, the actuaries have already taken that into account. At least they've told us that they took it into account. But we do worry about there's a lot of moving parts in the Medicare numbers. So, for example, in 14, the MedPAC is estimating that DISH actually drove up the Medicare numbers by 0.7% because of all of the Medicaid expansion that has happened around the country. Medicare uses Medicaid as part of its formula to determine its DISH payments, and so it actually drove up the number for 14 according to the MedPAC analysis. So there's a lot of ins and outs, and we won't actually know what the Medicare update is until we get through that process in the summer.
It's even more reason to be conservative on the number.
I think it's a reason to be conservative, or at least to look forward, but it may be that we need to go into the process of saying, well, last year we had an adjustment that we looked at again in January. So we said, we're going to go ahead and make this adjustment. We can look at it again in January. We may need to come back at January and say, we're going to go ahead with this adjustment because this is the best information that we have, but let's see how we're doing on the Medicare test, and we need to have some guardrail system in place so that if we're not where we need to be on the overall test, or if we're not where we need to be, that we can come back and evaluate that. So I think that could be a different way of addressing it, of focusing on some guardrails that could be figuring out what some guardrails could be put in place during the year if we're not keeping that 2% differential in place, or if there are some other, as we monitor and we don't have that differential statistic in place, or if we get some sense that there's a reasonable Medicare change that needs to be taken into account, and so that we could discuss at that point, the reasonableness of it and the appropriateness of it, and how it should be thought of in the context of an all-payer system. So, if they decided to offset SGR against the hospital rates, we might not think that that was reasonable to reflect on an all-payer basis against hospital rates. But if there's some productivity adjustment that's made, that might be a different conversation. And one of the other things that Medicare is doing that we'd like to put on the agenda to think about, even if we're not going to address it right now, but they're clearly focused on making hospital outpatient rates equal to doctor's office rates, and whether we need to make some adjustments to our system, not for fiscal 15, but for fiscal 16, to do similar things and how that would impact things. But that's kind of a different topic and not really related to the update itself, but it is something that is arising out of some of the work that we're looking at.
And Donna, you mentioned 1.7. Have the forecast changed? I mean, the last I remember was 1.9 for 14, 1.6 for 15.
We have the forecast. We have the new forecast numbers that we can share.
Okay.
We don't want anybody to hang their hat on them though, because 1.7 is the forecast for 14, and 1.7 is the forecast for 15.
Okay.
All right. Again, this update is just to get us, through past July 1st, and into the next year, we think there's still a significant amount of work that needs to be done in the future in looking at providing hospitals incentives to control utilization both overall and on a Medicare basis. But the fact that hospitals are going to be under global budgets, that provides them a lot of incentive to control utilization and to provide, care in the most proper way available. So we think by signing these hospitals up for these global budgets, that is going a long way to help us get to where we need to be. And we have, as I said, Donna's been doing a great job in signing these hospitals up.
That was going to be one of my questions, is that we're working this model under the assumption that 80% of the revenues will end up in a global model. So I think it would be helpful if we can get an update as to whatever the latest results are. The last time I think you did a more formal report, listed out the hospitals was about 53% of the revenues that were in the global budget. And I think if you work through the math of this, if you put in 53% and 47% for global versus non-global, that would move these numbers down, in fact, mathematically. But what I do want to talk in a couple of quick
numbers
things.
are up a little bit, but we're not. We'll be ready to announce in another week or so. But
Okay.
but by the next.
And I know you also
next
don't want to
update.
announce till you also announce it first, probably to the commissioners. I appreciate
Right.
that.
So we do expect these numbers to rise based on activities of the last week.
Good. Okay. But I do want to point out a couple of quick things. First, under the decreases, I believe there's a math error here.
Okay.
If you add up A, B, C, I believe that's a minus 1.87. And so then the total revenue growth then comes down by 0.4, as well as the revenue per capita. If I've done my math, and I think I double-checked the additions, I think the math there is fine, but I think there's an error there.
Good.
And, all right, so that's the first piece.
It'll deteriorate when we put the 0.8 back in, so maybe that didn't get carried down.
Right. But what I'd also would want to know is, clearly these are all percentages of an increase over a prior year's number, or if you will, in this case, I'm assuming fiscal year 2014. So it would be helpful if you could share with us what that projection is for fiscal year 2014 revenue, so that we're all on the same page and working through estimates of what the impact of these different issues are. Because I would have calculated slightly different adjustments for MHIP, uncompensated care, the Germantown Hospital, based on what I would have projected for fiscal 14. So that would be helpful if we could get that number as well. And then in terms of components of revenue changes or decreases that I believe needs to be added to this model, we know that the uncompensated care reduction, the MHIP reduction, result in savings to all payers, including Medicaid. And that should result, because I don't believe Medicaid included the anticipated reductions in those two items in their budget, that should result in Medicaid savings, which should allow the Commission to reduce the amount of the Medicaid assessment in fiscal year 2015 rates, which again contributes to savings to all payers, including Medicare. So I believe that as we work through this, and before we finalize this recommendation to the Commission, your recommendation should include an estimate of that savings reduction to Medicaid, and what the general fund impact of that would be, and what the reduction, the assessment that we could build into this model as well, because that should be something we should be willing and able to count on in terms of revenue growth or reduction in revenue growth for next year.
We can get you the 14 figures as soon as we have our final head count on global budgets. But we should be. I think we'll be able to get a number for that. And and it might change the percentages a little bit here and there. Since the percentages might have been done off of calendar revenues, in-state revenues in some case. For example, the Germantown Hospital is based on in-state revenue calculation because it's all in-state. It's going to be all in-state people. There's not going to be a lot of people driving up out of Washington, D.C. to go to Germantown Hospital. So, so there are a few nuances, but yes, we can get some updated figures to you to kick the tires, especially thanks for the math error.
Can I ask a quick question? How does this per capita increase compare to what historically has gone in the state? Because you're limiting per capita growth to 2.68, which is almost a full percentage point below what we have to do for the waiver, if I'm understanding this right. What have we been running for the past few years? I'm assuming a lot higher than that.
Over the last few years, we haven't been running. Our total increase in revenue has not been that significant because volumes have been decreasing over the last few years. So this may be...
We had an inflation constraint to 0.3% that depressed the per capita revenue increase last year very substantially.
But put it in context of how drastic a change this is over the past.
Wasn't the 3.58 the average of 10 years or something?
Shule
may have the number off of the top of her head.
I remember what we were talking about for the last 10 years, but more recently you are correct, Jerry, that in part because of the lower unit rate updates as well as the lower volume growth, the per capita growth has been more in the 2.7, 2.5 to 3 range or lower. But over the last 10 years, when we put the application into CMS, it was 6.8%, was like the 10 years through 2011 average in per capita growth.
The thing that you do have to put in perspective, if you look at this, though, is the uncompensated care change, which is a net of about, let's use 0.8 in the calculation, is a net of 0.4. So a net of 0.4 that isn't costing the hospitals anything because it's reducing their uncompensated care. So I wouldn't count that in my thinking as offsetting the 2.68. So then I would add that 0.4 back, and that would get me up to about 3.08. And then the MHIP adjustment is similar. It's not costing the hospitals anything, so it's a 0.45. So it really is, at this level, is if you add those two adjustments back, it's 3.53. As far as kind of real economic value to the hospital, so that would actually be a more favorable situation than say last year. So it's definitely not. It's not tighter than the recent history, and whether it's tight or loose depends on your perspective of what's happening with revenue growth. And at least the charts that I'm looking at on an all-payer basis from a national perspective, that number's a little bit under the all-payer national charts. But that's kind of my general perspective. Do you have a perspective on that, Stu?
No, I mean, it sounds like that there's still, I mean, yeah, I think you're right, and you know, there's still a cushion here that over time, you know, the system will play out. So we'll see how we're doing.
And again, I would add, and I think I commented on this our last meeting, or at the commission meeting perhaps, the set aside for unforeseen adjustments, that's probably historically a little bit bigger than what I think we've done. If you call that slippage, which was our old term for these unforeseen events that occur throughout the year that we adjust for in future years. And I think I had asked that in a previous meeting if we could see what that history has been, because we may have added more in that set aside, if you will, that historically we've needed for those kinds of unforeseen adjustments, which could lower these numbers even further. I mean, if we found, for example, historically, those unforeseen adjustments, one of which would have been allowing for some of the CON numbers to come through, like the Germantown Hospital, which we've separately set aside. If that's been, let's say, 0.25 historically, you could lower that amount down to 0.25, and again, that flows right down to the bottom line of this model. So I just think that's just something I'd like a little bit more history about to see whether we need to set aside that amount of money, or whether, and again, this goes back to the point of how constrained this number may be. The Advisory Council of the Commission has urged that and understood this tension between how low you make this number versus how much you need to have invested for the hospitals to be assured of long-term success under this waiver, not just the short-term success of controlling the cost. And part of that the Commission has recognized in the infrastructure investment, but we don't know today whether that's going to be all that hospitals need to be successful. So to the extent
I could say for sure that it isn't, that the hospitals will have to invest more than the infrastructure adjustment. It's right. Not nearly enough.
Which serves to suggest there's a built-in productivity adjustment in here that's not reflected for even global hospitals. But that's why I was suggesting that if you didn't need as much for the unforeseen adjustments, that would give you some flexibility to put some additional revenue into the infrastructure allowance, because I think the real issue here is, and I appreciate the Commission's challenge here, is this tension of getting that number below the 358 ceiling, also addressing the Medicare savings, those challenges, but at the same time making sure that we've got enough invested in the infrastructure in the efforts we need to assure long-term success on not just meeting the cost containment goals, but also the quality improvement targets, other targets that we're required to meet in this new waiver as well.
Now, are there other comments? So, John, your comment was to make sure that whatever we do, that we take into account the impact on Medicare. Are there other comments about the specifics? And I know Shule is going to get a little bit more into the shared savings adjustment, and I think there might be some discussions about the demographic adjustment, although that shouldn't, hopefully that won't affect our overall decision as long as it's coming inside the general framework that we're looking at. But
hey, Donna, a comment here. I know there is a great reason for all of us to have some caution going into the first year. No one wants to trip over this line. So rather than debating what happens in the next 12 months, what's the likelihood that if we learn that, first year and a half out, we're doing well, and let's say that there is some number that that is below the cap that we're achieving right now, the 2.68 occurred, not the 3.58, whatever the numbers are. What's the likelihood that in a next year, following year, this number could be recovered based upon the investments that need to be made? We learned that global budgeting infrastructure is more expensive. What's the chances we could recover this in a second or third year? is that off the table? Because I think if it's on the table, some of this concern about short-term and me and my side of this equation wanting more certainty now, it does take the edge off. Any chance, or is this, once this year closes, it's gone?
Well, the way the formula is written is it's cumulative. So the test is a cumulative test. So it counts from the beginning. The Medicare formula has an annual measurement, although it's a cumulative test.
Right. Exactly. Yeah, I think we all know the test. The question is, what's the tolerance?
Well, not everybody knows the test. So
okay, I'm sorry.
You know it because you've
been around it a little bit.
You've studied it, but basically the test measures the savings or dissavings from the beginning of time. So beginning January 1, 2014, with the 3.58% per capita increase, if the increase comes in under that number, then it creates a savings, and effectively that savings carries forward. So it's not like it goes away, it carries forward in the analysis over time. And I think there's some policy questions of what caused the underage. So if the underage was caused by an uncompensated care reduction, the commission wouldn't easily decide that that ought to be passed back to the hospitals, because that wasn't a policy that started in the hospitals, it started outside of the hospitals. On the other hand, if there was an underage that occurred because we had the 0.5% set aside, and we got to next year, and for whatever reason more money was needed into the system because we needed to invest in infrastructure, or because the economic recovery spiked some commercial volumes, and we had to figure out how to pay for them. So I think it would have to be a situational analysis of what is it that you're trying to fund and why, and what was the genesis of the savings, and what impact would it have on the Medicare test. So I think it's really a fairly detailed policy analysis to go through that discussion. I think we could spend time going through some more of that discussion after the update so that we could perhaps start to lay out what the thinking process would be to help people get to a point where they could think about it more rapidly.
Yeah, I think that would be helpful. If not, we will all, at least the hospital side, will be thinking about, I can't speak for everybody, but the here and now, because we've kind of been living that way for the last handful of years. We're fighting and debating every single year, every single measurement. And to the extent that there is a broader perspective that gives some confidence that this, for example, this 0.9 in my example, or the 0.5, whatever it is not off the table in the future, that helps a lot if we can get some thought around that.
Yeah, I think if you look down the stream at the Medicare projections, they do go back up after a couple of years.
Correct.
And in order to, and I'll call that an upside down situation, because it actually presses, if we actually have that big of a Medicare increase, it gets fairly hard to make the numbers fit inside this 3.58. So we might need to have that, if that kind of a trend actually occurs, if everybody who's working over the age of 65 retires, we're going to have a little bit of upside down cake there. And so I think that really gives you a situation where you can say, yeah, we need to grab that, and it's not going to affect the Medicare test because Medicare is actually driving part of it. Or inflation goes up to 2.7, and the model doesn't balance with the, say, 2.7. So I think it does actually cushion some of the things that might happen next year that aren't happening this year when we come back to look at the test again. With the addition right here and moving the number down to 0.8, the negatives here are about it's 1.47, not including the shared savings. So that does help against that 2% reduction that Medicare is planning on making for DISH. To balance that out in the equation. So you wouldn't want to eat into that at this point in time because that could put you in a bad spot on the Medicare savings test. But at least that's some of the thinking that at least that I've been having. It's maybe a little muddled, but we could do it some justice by getting down the road and having a formal discussion about it.
I hear good things in your comments. It's good. Thank you.
Other comments about the next step in our process is really to take this forward into a draft recommendation with the commission for the commission. So I guess are there other comments about this this layout with the idea that Jerry set out with the global insights being the top line for the hospital types 1 and 2, and the shared savings adjustment, which Shuli will review in a minute, and then a subtraction that is still a little bit moving, but of about 0.7% based on prior years for productivity and ACA adjustments for non-global revenues. Are there other comments on that? Do we want to move on to Shuli?
I'm passing out a table with hospital results, and I apologize to participants on the phone. We will send the files to you by email after the meeting. So the shared savings policy was approved by the Commission in the late spring last year, and the policy is kind of the idea is similar to the Medicare readmission reduction program. Back last year, we were, to receive an exemption from the readmission shared savings program, we had to have a similar program in our state. And we designed our program a little bit differently because in the Medicare program, the Medicare reduces the rate based on the risk-adjusted readmission rate of the 3 conditions. Whereas what we had is we already had ARR program where we had the bundles, and then we had TPRs, which we had the global budgets. The idea behind the shared savings was hospitals were saving, letting aside the cost of resulting the reductions. The idea is if hospitals are reducing their readmissions in the ARR, they were keeping 100% of that savings. And in the TPRs, it was broader, but again, for the readmission side, if they are reducing their readmissions, they were keeping 100% of those sharing savings. On the flip side, if their readmission rate was increasing, they were at risk at 100%. The shared savings program designed so that the part of that 100% savings was shared back with the payers. And last year, the Commission wanted to have a statewide shared savings amount of 0.3 of inpatient revenue that was built into the rates. And this year, rather than doing the numbers on an inpatient base, now we are kind of talking about an overall total inpatient. So the numbers don't look very same, but the analogy is the same. So this year what we are proposing is 0.4 of the total revenue of hospitals. What you have now is the methodology is what we do is we calculate the risk-adjusted readmission rate, which is in the column C. So this is calendar year 12. And another wrinkle here is these readmission rates are different than what we approved in the readmission incentive program, which is the CMS measure. This is based on ARR bundled program measure that we have. Again, the idea is based on that measure, hospitals can save based on these rates. So for Meritus Hospital, let's take as an example, their ARR readmission rate is 8.22%. So if they reduce it, they save 100%. And the ARR readmission savings, the measurement is based on only the same hospital readmission, and also it excludes the planned readmission. So this is the opportunity, if you will, that hospital has in terms of saving from the readmission rate. Based on this rate, what we estimate is the reduction required in this rate to make up that target that we have. So if we set the 0.4 as a total revenue reduction, what would it take to reduce the readmissions as a percentage to achieve that saving? So in our statewide calculation, the 0.4 savings is equal to 9.17% reduction in readmission, which is on the top of column D. And there is a separate schedule which I will send in the email how that is done. But basically, 0.4 is about $6 million in the state, and on average, our admissions are costing $16,000. So dividing those two, we estimate number of readmissions to be reduced, and that as a percentage is 9.7%, 9.17%. And then what we do is based on the base readmission rates, we take those percentages out of the hospital revenue. So for Meritus, again, it will be 6.22% times 9.17%. So that comes to be at 0.75% for this hospital. And then, so you can take these percentages as the reductions in their inpatient revenue, because the readmission rate is the inpatient revenue. And what we do is we use the proportion of inpatient to the total revenue to come up with the total percent reduction in the overall hospital revenue. So in this case, 0.75% times 62% for this hospital gives us the 0.47% total reduction for that hospital. And if you look at down, the readmission rates are very close to each other, and therefore the reductions are very close to each other. And I think some of the very few reductions are in some of the small hospitals, and I think Kernan should have a smaller one because of the nature of the intra-hospital readmission rate. And I just wanted to make sure that this is kind of the application for fiscal year 15. It's not the net impact because we are putting that 0.2% back to the rate. So this 0.4 is kind of the 15 reduction in the rates. If you're looking from the hospital perspective overall, the net impact, you need to subtract what you had in the fiscal year 14 rates.
Shirley,
Yeah.
I'm sorry, just really basic question. Can you go back to C and just tell us again what is the rationale for C, or how is C developed for each of these hospitals?
So C was developed based on our bundled payment methodology where we have a 30-day episode, and we just include the same hospital readmissions into the readmission count. Okay. And then the idea is in our ARR bundled, hospitals have the savings only for readmissions coming back to their hospitals. Obviously, if they reduce in the readmission going to another hospital, that's a saving for hospital B.
So C reflects the percent that the 9.17 would apply to.
Yes, okay. And that's their percent of discharges that are readmissions.
Okay, thank you.
And on a risk-adjusted basis, so this risk adjusts for the case mix of the hospital.
And again, this is on an all-payer basis.
Yes.
When we finalize this, are we going to, again, continue to use the calendar year 2012 risk-adjusted rate? And is that because it's wedded to the ARR program? Is that probably the best way to explain it?
Yes. And also in terms of the timing, we won't have the fiscal year data way past July update. So we made the decision that our measurements were on a case calendar year basis, so we have the number ready for the update.
And I was just really raising the question whether you could use a calendar year 13 number there in column C, if you have that data, whether that would mess this up in any way. Again, because I understand the tie back to the ARR program and using the intra-hospital, but I'm just wondering whether we have different risk-adjusted rates for calendar year 13 under the current methodology, and whether that would move these numbers a little bit for each hospital.
They would. I think we can explore looking at the calendar year 13 numbers. So the idea is in the fiscal year 14, hospitals reduced these rates, so they did some savings from these numbers. But certainly, I think we can also do calendar year 13 as a base.
I think we have the data now. I mean, I think that we got it. I think we got it earlier with the 60 days.
Yeah, and I understand the math of having to come back to the -0.4 and how that will affect some of the calculations. But I'm really thinking just in terms of the
hospital results one more year to the calendar 13. Yeah, we can do that. I think we used 11 last year, but then we were getting our case mix data a little further behind, and so since we've sped that process up a little bit, we ought to be able to get it in as long as we think the data is pretty good.
Yeah.
So the reason for using this methodology as opposed to a brand new one based on the new Medicare methodology is it does represent the savings that can be done inside of each hospital, and the new methodology has other if we do inter-hospital readmissions, we really have to think about that and the impact on the calculation, and we also have to take into account socioeconomic status or some kind of peer grouping. If we introduce that broader concept, we might want to do that next year, but we're not ready to go with that at this moment in time. All right. Are there other questions or comments?
I just want to make sure I have this straight. So if these numbers are the ones that are used, and they may not be, they may be updated, but so what we're saying essentially is if a hospital in Maryland reduces its readmission rate by more than 9.17%, it keeps the difference. So the state's taking out the first 9.17% of the adjustment. So if actually Maryland hospitals have reduced readmissions between calendar year 12 and calendar year 13, that 9.17% would end up going up, right? So, okay.
It might go up a little bit just to make the scaling work, yes. Other questions or comments?
I think it's because it's just not totally sinking in for me yet, but I'm looking at the example of Holy Cross with a 6.9% adjusted rate and a Harbor hospital. It's like Holy Cross is about 4 down, and then Harbor's maybe 2/3 of the way down, 6.9%. So they share the same readmission rate, but because of the mix of their inpatient to outpatient, the differential of 0.44 versus the differential of 0.39 seems pretty significant. And I don't know if that's, I mean, I have to think through if that seems appropriate.
Well, since it's on the if you can think about the inpatient as a base, then they have exactly the same reductions in dollar amounts, right? So here what is conflating is the proportion of their inpatient revenue when you think about a total reduction. But in terms of this savings, opportunity of the savings, those two hospitals have exactly the same percent readmissions and exactly the same reductions of inpatients.
Maybe another way to clarify this is if you just did this as an inpatient-only reduction, you'd do the minus 0.67 that you have at the bottom, as opposed to the minus 0.4 on an all-revenue inpatient, outpatient basis.
Yeah, and so then Harbor and Holy Cross are getting exactly the same reduction, so they're both getting a 0.63% of their inpatient revenue reduced, and it's not being extrapolated onto the outpatient. We're just converting it to a total rate so that we can. And maybe the math of it all works out.
If you have a larger inpatient base, as a percent, you have a larger reduction, I think.
But you, from an incentive standpoint, you achieve the same percentage of the goal, if you will. So, but I guess, it's just adjusting the base equally, as long as the math works out.
All right. So I'm going to move to demographic adjustment, and there are two issues related to the demographic adjustment, and some of it is going to be covered in the potentially avoidable one, but I would, I think it's in the last page, there is a table in your package called Demographic Volume Growth Based on Revised Age Categories. It's letter size, a very small table to read. It's a single page, separate from the presentation. All right, yeah, it could be at the very end. So we had a meeting with the demographic subgroup members, and I see Gary Wogan in the audience who was very helpful at that meeting as well, and we had some other non-work group members who were very, very helpful. What we discussed at that meeting was, as you remember, you were thinking about revising the age categories, looking at gender and race, whether we want to have those as part of the adjustment. This table in front of you is based on the revised age categories, which are listed at the bottom, which separates the younger group so that we capture the newborn growth a little bit, 0 to 4. And also, it breaks the middle age group. Originally, we had 15 to 54. Now we have the childbearing age group kind of separated in the model. The important thing here to consider is we know that their average charge per person is different by age group. It is different by gender, and it is very different by race and ethnicity. However, what is impacting the demographic adjustment is their growth rates. If in the base the proportions are different, but they are growing equally, you would end up with the same adjustment at the end of the year. So because of that reason, we didn't include the gender and the race in our calculations. And the race has also other implications because of the location of the minorities in the state being in the higher expenditure. Baltimore City has much higher hospital expenditures compared to the other states. So when you look at the race comparison to the whites, not only you're comparing the ethnicity, but you're also comparing the rate structure of different hospitals that we need to take into account. Right. So in terms of the basic methodology, I briefly described to you in the last meeting, and I'm happy to go into as deep as you would like to, but I thought you would rather have it at the high level. What you have in front of you is, after the hospital name, you have the EC max calculated. So these are the volume calculation, which is a standard calculation, case mix adjusted equivalent discharges, combining inpatient and outpatient for Maryland residents. And then I calculated here the percents for each hospital. So again, for Meritus, it's 2.1% of the total volume in the state. And then based on the EC math in the zip code and age cohorts, we attributed the population for this hospital, which is 1.9% of the state total population. The reason why you see a discrepancy or differences between the percent volume versus percent population is a function of hospital having a higher market share in a high population dense area. And then on the next column is the population growth rates calculated based on, again, at the age, zip code, and age. So for this hospital, the population growth is 0.46%. If you go down all the way to the end, you see for the statewide, from the Claritas data, we have an estimate of 0.59% statewide. And if you remember, the Department of State has 0.71. So that's something to keep in mind. The next column to it is the age-adjusted growth rates. If you remember, for each age cohort, the elderly is, on a per-person basis, twice as more expensive as the younger population. So if you take that into account, then the growth rate for this hospital goes up to 1.12%. So that's the age weights that we have, which I'm going to get into in the next presentation. And then we have the power reductions for each of these weights. So it reduces the population growth rates to 0.91 for this hospital. And at the end, we do a 50-50% variable cost factor adjustment to come up with the demographic volume estimate for each hospital. So if you go down to the bottom, as I mentioned, the population growth without any adjustment was 0.59%. When you take into account the aging of the population, the volume growth expected is at 1.31%. And then if you reduce the POWs, then we have a reduction, and it goes down to 1% approximately. And then we take the 50% to come up with the, so this is the 0.53. If everyone was on global budget and we didn't have any volume leakage from the system, the 0.53 is the number that would have gone into the table that we discussed earlier. So we had, you know, during the discussions, I'm sure, I think probably I don't have to speak on behalf of them. There are some questions about or issues in terms of the final. I think the age breakouts are reasonably well defined. And if you try to do more refined one, then there's an issue of the small size comparisons. And also, the estimates are, they don't have very much exclusions. We just have some trimming for the high charges, but we try to include all the volume in the state in the calculation. So there is not much impact of any of those changes into the calculation, I believe, but there is a significant impact of the power adjustments and also the 50-50% variable cost factor. And I'm going to stop there and ask for questions in the comments.
So just to be clear on that, so then the greatest predictor in terms of cost and utilization that you're putting into this is age and not the racial or socioeconomic.
That's correct.
But what you have to understand is that at the end of the day, the factor gets multiplied by actual cost. So the actual cost of each hospital is already reflects the higher use rates of the that are driven by socioeconomic status and race. So, for example, Baltimore City, the cost per person is much higher, and it's not, even though there's not a break in this, the number that's here gets multiplied by a higher cost to start with. So each additional person that is added to the population or subtracted from the population in Baltimore gets more money attached to them because they're in Baltimore, or they're in a zip, you know, they're in a hospital that has a higher use rate because it's in a socioeconomically distressed area of the state.
My follow-up question then is, if you're using age, some hospital demand curves where you see the demand for hospital services rise at certain times. One is in the obstetric population and the young adults, and then a hospital demand that seems to rise around age 65 and above. Will you be able to account for future changes in technology and practice that probably put that older age demand curve even higher into the 75 as more and more of the 65-year-olds are treated on an outpatient basis? To look at hospital demand and usage as to actually what should be expected as technology advances and care may be moved to an outpatient setting or length of stay reduced even more in a population of what I would call the young elderly.
This is a short-term, this is taking fiscal year 2013 breakdowns by age and trying to predict only one more year. As we update these weights, as the care practices change, that's going to come into the, into calculation a little bit. The other issue is the adjustments around the avoidable utilization. We try to do that a little bit prospectively because our emphasis is on avoiding those admissions, and elderly tend to have more of those. So we try to do some of prospective adjustment to it, but I believe since this is a short-term projection, we probably don't need to worry about those big shifts.
But the avoidable utilization, and Julie is going to get into the issue, when it does disproportionately impact the aged population, because that's where in Maryland the higher use rates are concentrated compared to any benchmark that I've looked at. The higher use rates are concentrated in the elderly, and so we do believe that the avoidable utilization is more concentrated in the elderly because they haven't been in managed care in Maryland, and both national trends and Maryland trends are showing that. That's why we have a differential statistic of 2% between the use rate increases of the Medicare and the use rate increases of the commercial or the non-Medicare population, or actually the total. So that that's what that difference is driving the use rates to be lower, the use rate changes to be lower in the Medicare population. So we're trying to focus on using a multiplier that is lower than historic actual to reflect a better practice, if you will, in terms of utilization patterns. And we think that's really important for a couple of reasons. So, for example, I would point out, say, Holy Cross, just to give you an example of this. Holy Cross, who has a fairly young population of patients, the difference between its population growth and its age-adjusted growth and its POW-adjusted growth, there isn't a huge disparity, but and if you actually look at Holy Cross's data, it doesn't have as many avoidable utilization because it doesn't have as much elderly population. So this gives that credit to Holy Cross, if you will, when we're applying the population adjustment for a demographic growth in that area. Whereas another hospital, if you looked down through here and found one that had a big age adjustment, then they would have also more of a POW adjustment. And in fact, they do have more opportunity. And if you actually look at the data, you would see that those hospitals are having more utilization reductions from their Medicare volumes going down. So, we think this helps to play out that discrepancy and effectively leave more of a population adjustment, say for Holy Cross, that has more of a growth in the below 65 population, and not nick it, if you will, as much for the change in the POW adjustment.
Yeah, I would agree 100%, and you're right on target with the POW adjustment not being available to the younger age population, especially you're talking about a higher stretch rate. That's not an avoidable admission, but if you get into the elderly, there's many more opportunities to cut length of stay, to avoid the admission in the first place or the readmission. And as long as you have that built in going forward, because you may be surprised in what you see. I've been in healthcare long enough to say where the demand curve was much younger in terms of a 50 plus that you would expect, and then it got up to 65, and now we're even seeing that it's a bit more towards the 85 plus. So that practice patterns will change as not only the care types of care and technology change, but also the population health itself changes in the elderly.
Thank you. Do we have more comments, or before Julie moves on to the PAL? We can come back to this, or we can listen to what Julie says about the PAL first.
Yeah, just some quick comments, because again, I think we all recognize there are a lot of things we could do to perfect this model. I'll just suggest a couple of things where we have concerns, and we could take this perhaps back up with the demographic subgroup. And I've raised this, I think, in that setting as well. First, the way in which we adjust for the ECMADs for the outpatient essentially assumes that the case mix of the outpatient business is the same as the case mix for the inpatient business. The only place where we adjust for that is on the inpatient side, but then when we do the revenue adjustment, it's basically making the assumption that outpatient case mix is equivalent to inpatient. That may not be the case, but it's going to have small impacts, I think, on this number. Second, at this point, we haven't had an in-depth discussion about how the PAUs are calculated. Separately, I know, and it's on our agenda for a later meeting, what the variable cost factor should be. I've looked at what you could do for those last two columns instead of making an adjustment for PAU and variable cost factor, but instead making an adjustment to the third column to the right, the age-adjusted growth rate, that brings you back down to at or below the 0.7 that is the statewide population growth that the Department of Planning is estimating. Or at the very least, I would argue that while we did this at a zip code level and the Claritas data is showing a 0.59% population growth, if we don't gross that back up to the 0.7, we're making an artificial, or if you will, additional adjustment to the population growth simply because we're using two different sources of data. So I think somewhere these kinds of adjustments need to be made, whether we call it revenue neutral adjustments. We need, to me, I believe, adjust the demographic, the population numbers for age, but then get it back down to, I would argue, the 0.7, and have in a separate policy, part of which we're about to discuss, how we would handle potentially avoidable utilization by hospital, how we would handle a variable cost factor adjustment, because we haven't, I think, gotten into enough adjustments. And I'm just concerned that if we make those adjustments here, it's almost predetermining what the outcome of those other discussions would be in terms of what the variable cost factor should be or what the POW adjustment should be for each hospital. So again, I don't know that we want to belabor that here. We're already getting towards the end of our 3-hour meeting, but if the best place to address those concerns is in the demographic adjustment subgroup, I'd like to take those issues up there.
How about I go through the potential avoidable presentation so you have a better idea about what those are and how it fits into the demographic, and then we'll take up what my comments are. Sounds good? So I'm going to go through the PowerPoint presentation that you have. we wanted to have the kind of the context of the potential avoidable utilization also in terms of the guardrail policy. So again, this is almost, very early stages of thinking, if we are making sure in our schedule that we are going to hit the all-payer target based on the update factors and the volume governor and the demographic adjustment. But what happens if we hit the all-payer target but we don't hit the Medicare target that we have? What should be the guardrail policy that we should be thinking about to, one, make sure we hit the Medicare target, but two, if we don't hit it, what kind of adjustments we need to be making, come not this July, but the next July. And here, we've been discussing these in terms of the global budget policies. I put two options that were kind of put forward. One is, not give inflation on the POW revenues, the percentage of POW revenues, or create a program that will be based on some target POW reduction similar to what we have on the readmission side. And there might be other ways of thinking about this, and we are looking forward to some creative ideas on that front. So
I just want to say that we're not proposing a guardrail policy today. We're just wanting to actually introduce a thought process so that we can start thinking about it going down the road, but start actively thinking about it in the context of having a policy in place that also our model is different than the Medicare value-based purchasing model, and so one of the things that we need to think about is how can we get appropriate value-based purchasing credit, if you will, for risks that the Maryland hospitals are taking. One of the risks that they're taking is that they're saying we can avoid avoidable utilization, but if they don't, and we have to come back around, then this is a policy that would put quality-based utilization at risk if we aren't meeting our guardrail. So we're not proposing this today, but we're just introducing this kind of as a concept to think about as we move down the road, and also recognizing that we have to up the ante on value-based purchasing. And this will be one of the thought processes that we can put into play, so that if we're doing the job we need to do, we can avoid penalties. But if we're not, then those penalties can be based on things that we have endorsed as part of the model. So if that makes any sense. So that's really just the context of the framework, and then really just going through and describing a little bit more about what's in potentially avoidable utilization.
So Donna, I just have another context question. Is this the subgroup that is primarily charged with determining what that policy will be? I know there's multiple subgroups going on at the same time.
Yes, this is the guardrail subgroup, and it's on the agenda to be taken back up later. But we just wanted to start the thinking process because we actually do it. The later has to be not too late if we're actually going to use it for a value-based purchasing program going forward in our discussions with CMS. So, and then also because it's now part of the demographic adjustment, we wanted to spend some time talking about it. And I think the performance measurement work group has also been looking at the PAL definition.
The measurement side performance work group reviewed some of these and the definitions, and they are going to be looking at more expanding those measurements in May. So they are kind of thinking in terms of how we measure it, and then this work group is how we apply those indicators in our payment policies.
Okay.
But obviously, the distinction is kind of for practical, pragmatic purposes. Those questions are very interlinked with each other. So the definition is, came from the performance work group, but the keywords are in avoidable utilization is unplanned and preventable. And you need to keep in mind that when we define the potential avoidable utilization, up to this point, we are calculating certain measures, but we are agnostic about what the percentage that is actually preventable in those measures.
No, now I'm on. Thank you. I see. When it says hospital care that's unplanned, are you talking about only inpatient care? Are you talking about inpatient and outpatient services?
Both.
Are you talking about emergency room services?
Yes, but I would say that our current measurement is more inpatient heavy. We don't have good measures on the outpatient, and that's something that performance work group is going to be trying to get at.
And we also intentionally are not teeing up a lot with the emergency room right now, because getting out of the gate and into a new system, we don't want our physician colleagues to think that we don't think emergency room care is necessary. So the only thing that we have now in the bucket for that falls out in this calculation is for patients that come back to the emergency room within 30 days of an admission. So it's kind of a readmission, if you will, related to an inpatient visit. But we weren't anxious, at this moment in time to create a flurry of concern and activity about whether it's appropriate for a patient to visit an emergency room, recognizing that long-term there are patients in the emergency room who don't need to be there, who can be treated in primary care, and we need to work with our physician colleagues on that front, but not to put our patients or our doctors into a worry position if they send a patient to an emergency room.
What triggers, though, to follow up your question, what triggers the PAU, the preventable utilization penalty? Because as I brought up before, the care provider on duty, not necessarily a physician or a nurse practitioner or a physician's assistant, in a nursing home picks up the phone, calls the city or county ambulance, and off they go to the emergency room. And that is well within maybe a 30 days of readmission. It may not be deemed necessary. It may be something that the patient has to be there for a little while to be evaluated to determine whether or not it's necessary. Just the fact that the patient lands in the emergency room trigger that penalty?
Currently, there is no penalty. We are just measuring it. But in terms of measurement, if the patient comes back to any of the hospitals in the state to the emergency after an inpatient stay, that is part of the measurement.
But there is no penalty.
There is no penalty.
We haven't put a penalty on it.
Okay, but will there be?
That's for you to work on. That's up and coming.
How are we really clear? So they come back to they come into the emergency room within that 30-day window. There's no penalty.
No, it is there right now. It's measured as a potentially avoidable utilization, just like a person who comes back in for a readmission. Not every readmission can be avoided. Not every revisit to an emergency room could be avoided, but it's in the count. So the readmission count. Whenever we come up with a policy, we'll apply a percentage to the adjustment. We won't apply. It won't be a 100% adjustment of anything. So we won't say, oh, you had 15% potentially avoidable utilization, and that's about the percentage statewide. So we're going to just subtract 15% from everybody's revenue because that's what the number is. So nobody will do that. Just like on the readmission side, we're saying 9% is your reduction program for this year. Some percentage will end up being applied to whatever the policy is. So we might say next year the target is 10%. We won't say the target is 100%. It'll be some lower percentage.
You're impacting the demographic adjustment side.
Yes.
Has impact on the reimbursement.
Yes, so we're saying the use rates that are in the base are too high. This is one measure of avoidable. There's other people who think it should be a 30% reduction, and so this is.
I'm not debating that right now. All I'm saying is there is an economic impact of the calculation. Demographic adjustment impact.
Yes, and actually that particular adjustment, and we can take this back up in the work group, but that we're actually using that adjustment where we are using it to impact the reimbursement. We're using it as part of, and counting it as part of our value-based reimbursement formula.
Yeah, I'm just clarifying. Yeah. So there is an economic impact of the calculation, and I get why you're doing it.
And it's a tiny number for the emergency room at point.
Coming up.
Okay.
It's 1%. So in terms of just what we have currently in the measure, I've skipped the slide 4, so I'm on slide 5 for the time constraints. We have the 30-day readmissions, both intra-hospital and intra, so anywhere in the state if the patient comes back to the inpatient, that is included. But we are not including any planned readmissions like the chemos or the rehabs. They are all excluded. We have the 30-day ED visits and or observation visits. Most of the observation visits, as you all know, are coming through the ED, but there is a slight difference, so we captured both of them. And then on the potential avoidable admissions visits, we have the inpatient side only, and we are using the Agency for Healthcare Quality Prevention Quality Indicators. These are vetted nationally, endorsed by NQF, and publicly available, and commonly used by the public health community as well. On the outpatient side, we don't have any other measures currently. And lastly, we are also adding the cost of the potentially preventable complications that we have in the MHAC quality program. This quality scaling program is based on the rates and aggregate adjustments to the revenues. This one is looking at the cost of total PPCs in the hospital, if that makes sense, right? So this is, yep.
Can you just give it, what would be an example of the potentially avoidable admission? Not the readmission, but the
admission. Yeah, these are for chronic, or it could be chronic for acute conditions, but for diabetes, for example, if they're admitted for amputation, the thought process is that could have been prevented by appropriate ambulatory care services.
That's an extreme example, but asthma.
I was going to say asthma.
Asthma. So somebody who's admitted for asthma, or somebody who's admitted for pneumonia. So things that could have been treated in the doctor's office and an admission could have been avoided. So that's why it's called ambulatory sensitive conditions.
Or uncontrolled hypertension would be okay, good.
Mm-hmm.
Will you include in that lung cancer prevented by smoking?
I don't think it is there.
Should it be, maybe?
That's not one that you can treat in the doctor's office. Maybe you can prevent the.
Oh, I thought you included preventable in other ways too. Just preventable.
This is preventable by treatment in the doctor's office.
Oh, I'm sorry.
The other term that was used before was ambulatory sensitive conditions.
Okay.
So this is kind of very still health care-centric measurement.
At some point, you had population health changes. Okay, that's different. Okay, thank you.
So it ties in with the what we're trying to do as in reform on the physician side of getting that more care delivered in the physician's office and less care delivered in the hospital, of avoiding the admission.
Just a quick question, more of a clarification, because I understand the ED and observation is a small percentage of this overall numbers you've calculated. But for the patients who return within 30 days, ED within 30 days of an inpatient admission, or for observation, those returns, it doesn't make a difference whether they're related to the initial admission or not. So if I'm, had an initial admission for an orthopedic procedure, and then within 30 days I'm in an auto accident, I'd be picking that up.
Right. We are assuming that's randomly distributed, that one hospital is not getting all the unrelated traffic accidents to their admissions. They may be receiving it, but in terms of who they discharge, if you think University of Maryland, shock trauma is likely to receive those unrelated.
I understand that. I'm just saying that even if it's randomly or evenly distributed across all hospitals, what you're including in the adjustment is something that I would define as not potentially avoidable and certainly not related to the initial admission within the 30 days.
Yes, you're bringing up the same thing that is brought up over and over again on readmission. So it's not a different argument than readmissions, that it could be unrelated.
Right, and it may not be preventable. It is potentially so we are acknowledging this is not 100% preventable. So the chart is kind of the denominator on this chart is the total 14% that we calculated in the state. So about half of them are readmissions. 1/3 is PQIs, that's the ambulatory intensive care, preventable admissions. We have 18% in PPCs, and then only 4% that is coming from the outpatient distribution. So as you see, as we discussed, the outpatient part is very small. And there is an overlap, obviously, between the PQIs and readmissions, but it's not very significant. Well, one thing to point out, though, when I say not significant, we are looking at if a PQI is a readmission at the same time. Obviously, a patient may be admitted for one of these avoidable admissions, and they may have a higher rate of readmission back to the hospital. So this next slide, 7, is showing the distribution of PALS by age. And as we discussed, you can clearly see in the data the elderly has much more percent potential avoidable utilization in the inpatient side. And on the outpatient, you don't see that clear distribution, but it is probably a reflection of the measurement issue rather than the age impact on the avoidable utilization. So as we mentioned, we have this adjustment already built in the demographic adjustment, and we are thinking about what other adjustments that needs to be built in, because overall, conceptually, we want those volumes to be reduced and hospitals to focus on those admissions. What we need to do as a policy to incentivize that hospitals reduce those volume and then get additional rewards for doing the right thing. And in the GBR agreements, and we are reviewing the contract in the subgroup, there is a language in the existing agreements about the targets for PAL reductions as well. So I'm going to skip this and get to the numbers. So I'm now on slide 10. The way that is applied in the demographic adjustment, so what you have here is in column B is at the statewide level, the population growth by each age cohort. And then we estimated the age weight. So these are the ratio of average charge per person in age group to the statewide average. So if you go to 85 plus, on a per person basis, their average charge is, or average expenditures is 3.5 more than the average in the state. Right, thank you. 3.5 times. And then what we calculate then is the age-adjusted growth rate, which is kind of corollary to the hospital-wide that you saw. And then we estimate what will be the kind of expected expenditure growth if this age cohort grew by 1.3% and they are 3 times as costly, their expenditures supposed to grow by 4.5% in total. Then the PAL percentages are the inpatient and outpatient combined percentages that you saw in the earlier slide. So the 0 to 4 age cohort has 5% of their charges in potential avoidable utilization, and the 85 plus has 25% of their total charges in avoidable utilization. What we then do is we reduce these age-adjusted growth rates by these percentages So the 85 plus growth rate is reduced from 4.5 to 3.37%. Mm-hmm.
Should that be the full value of the PALs, or should it be some fraction of it that is what we think is unattainable improvement?
So again, since these are applied to the growth rates, it's still on your base. So what we are just adjusting is the growth rate, and
but some growth rate of PALs is going to happen. They're not all. I don't think anybody in this room thinks we can eliminate every PAL in that list.
but you're not eliminating.
But you're not giving credit for any of the growth in any of the PALs. So even the ones that can't be avoided, you're not getting growth rates.
But if you are reducing, right, let's say 50% are preventable. If you're reducing one of those, some portion of that 50%, your growth rate should be still reduced, even the other 50% is growing at some percent.
One can argue against better practices and say we shouldn't use a better practice use rate in a calculation. Mm-hmm. And if we actually look at Milliman, the use rates in Milliman, the elderly use rates for moderately managed are in the same vicinity as these adjustments for Medicare for the over 65 population. So these represent better managed use rates, and so to build a volume growth that builds in utilization that you think is avoidable isn't something that we're focused on doing at this point. We're not focused on building.
In that PAL rate, you've got all-cause readmissions as an example. So you've got somebody came to a hospital, and then 3 days later they had an auto accident, and they came to the hospital for the auto accident. That's counted as a PAL, correct? So I'm saying that that type of incident should be taken into consideration when doing this. That's all-cause.
Then we could do an adjustment based on Milliman and just take 20% off of all of the elderly. I'd be happy to do that too if we really wanted to go to that. But I think this is it's an estimate that's based on calculations that are applied to particular age groups. And but the issue is that we know from Dr. Cook's presentation that the older population isn't experiencing the same growth rate as the younger population, and we know that they have a lot of avoidable utilization in Maryland. They're poorly managed, and so we don't want to build a demographic factor that says, yeah, let's go at it and put more avoidable utilization on the books as an allowed volume adjustment.
I'm just commenting on the model. Obviously, if it's 20 or 14%, I'll pick 14%. That's my only response to that. But I'm responding to the model in that 14%, some percentage of it, I think we would all agree, is not avoidable. Because you've built in
there's other that is avoidable that's not up there. If you actually looked at the medical, and so these are kind of a predictor of the other ones, because these avoidable utilization are medical admissions, and there's a lot more medical admissions that we haven't put on the table yet that are avoidable, and these are very good indicators of those other medical admissions that we haven't counted yet. We haven't counted the admissions from nursing homes that are avoidable because we can avoid people having to go to the hospital for a UTI if we prevent the UTI, or if some of those are not yet counted here. A lot of them are not yet counted here, and the staff feels strongly that they have to be counted when we do a population adjustment. Now, we can do other adjustments and other factoring, but we really need to do something to take that off the table.
And the threshold question, yes, we can debate what percentage is avoidable, what is not. The threshold question is, do we expect them to grow differentially, right? Do you expect non-avoidable utilization in next year to grow substantially much higher than the historical level. Because at the end, this is applied to the growth rate, not the actual base. So I think, you know, if you are trying to refine this methodology, first we need to come up with what that percent is. And the second is how much do you expect that percent to grow in next year?
Just a quick question. I'm looking back to your previous spreadsheet where you did the POW adjustment and that demographic methodology versus the POW percentage that you have here, and it looks like we're using two different POW percentages. Is this spreadsheet that you have up on the screen now, this slide, where you show 14%, is that a different data source or fiscal year versus calendar year? Because my understanding is that in this previous spreadsheet that we were talking about earlier, the PAU percentage was about 18%, not the 14% that you have here.
Yeah, they are updated. It's related to the removing the Maryland's residents out of the calculations. You know, we've been still cleaning up that portion.
Okay.
And also in the base, whether you include the rehab hospitals and the freestandings, and those hospitals are not connected to CRISP. So these revised estimates, 14%, is kind of revising it and making it more accurate.
Okay, well, so we would circle back then and update the previous spreadsheet for these revised numbers?
When you say previous
The
one,
spreadsheet here where we took the
hospital-specific one.
The hospital-specific, yes. that calculation. And you, after you got the age-adjusted growth rate, you multiplied it by a POW adjustment. How is that POW adjustment, if I'm calculating it, that POW adjustment is about 82% of the age-adjusted growth rate, or if you will, an 18% reduction. How am I to understand that we would substitute this 14% for that back in this model? What's the difference?
So the differences are these totals are summation of each zip code age cohort growth rates.
Yeah.
So, but this one is at the statewide level, the impact overall. We can go back and do some more work, but they shouldn't add up to each other because this is based on a different base, if that makes sense. Right.
Okay.
This is a total.
Well, I guess I'm asking the question, why wouldn't we use this percentage?
It's using this percentage, 14%, using the weight for each age and zip cohort for each hospital and coming up with the new growth rate. So it is not an aggregate reduction of the 14% of these percents at the hospital level.
Right. I don't want to belabor it. I'm just
we can go back
about the differences. Thank you.
So what I'm hearing you say is that looking at this table, the greatest in terms of the growth rate is going to be in the 65 plus, which is also the greatest where you have the greatest cost and the greatest potentially avoidable utilization there. Mm-hmm. And if we don't keep a tight rein on that, that's the factor that is going to come closer to us triggering the Medicare waiver tripwire.
Right. Okay. So this is kind of conceptually has two strong points. One is we are not building the historical inefficiencies for the projected volume growth, and we are doing an attempt to get more efficient differences between age groups. The second is since the elderly has higher potential avoidable utilization, it is by design helping us to give lower growth for the 65 plus age group, helping us with the Medicare target.
Yeah, it's the greatest where you can get the biggest bang for your efforts, but then it also requires much more of a population global thinking on the part of hospitals as to what to control, because in order to control what hits your ED, you've got to work with your physicians, you've got to work in the community, you've got to work with your long-term care facilities so that they don't hit your ED mm-hmm. there. Mm-hmm.
Right. You have to work with your primary care doctors to get the prevention done in the doctor's office, et cetera, and specialists and primary care doctors to get prevention done in the doctor's office, to work with the nursing homes to get prevention done in the nursing home. So it's very tied into getting outside of the walls of the hospital, and that's going to be what drives the success of quality improvement.
Don, if I could add to that, I think this is a critical point you made, and I want to make sure that we don't lose sight of it. The hospitals control what they control. Physicians are the ones who make another series of decisions, and they are incented in a very different way. So this is the reason I bring it up is I happen to be a big proponent of what we're doing here. I think it's necessary, and I think I'm very optimistic about it. But I wouldn't underestimate how difficult this is going to be in the next few years to have alignment with other parts of the delivery system, which gets back to a comment you made about the population adjustment, the infrastructure that's built into hospitals' rates, and I think you made the comment that it could cost more than that, and I'm certain it will. It will. And I think it's going to take some time. That's why, you know, from my side, it's why I'm cautious about, you know, as much as we can do to make sure the hospitals remain strong throughout this and not keep whittling down the hospital's resources at a time where we need to create the energy and have those resources to make this big change. So I would ask that we think multi-year and not 1 year at a time, because this is a heavy lift. But I think I think the optimism is there.
Then the last slide is kind of also pointing out this is an immediate implementation in the demographic adjustment that we will be counting at the aggregate risk that we have. And finally, I just wanted to point out that we distributed 2 tables with the hospital-specific percentages. I would encourage you to look at it, the distribution, and that will help in terms of thinking about if we can use these definitions in a guardrail policy or additional policies if we are trying to drive the system to really focus on reducing the avoidable utilization.
And then before asking for other comments, back to your comment, Mike, of can we get back into the subgroup and kick this around a little bit more? I think, yes, we can. And also I know when we had the demographic adjustment before, right now the right-hand column adds up to 0.53%, and that's lower than what we were looking at before, and so we might need to address the you know, what we end up with in the far right-hand column of scaling that number a little bit differently to tie into the population growth of the state, et cetera. So we might need to kick the tires around on that part of it a little bit more too, as well as addressing other concerns that you have.
Thank you. That would be great.
Are there other comments or questions or concerns? Anyone from the audience who wants to comment? Brett McCone.
Hi, I'm Brett McCone from KPMG. Shule, just a quick question. On the one slide where you showed the total PAU, I think it was the charges on that slide, you know, that was for all payers. Do you have a slide like that or an amount like that specifically for Medicare and also Medicaid? Well, I'm sorry, I don't have that.
Medicare is 21% overall. I didn't look at the Medicaid one.
Okay, because I'm just curious as to how that, as you talk about, you know, what the future PAU reduction needs to be. I think this goes back to John Hamper. I think this was your point, looking at the difference between the all-payer expected growth and then the Medicare expected growth, and you know what we project the Medicare PAU to be reduced by, if that truly is the target area, and sort of translate that into, you know, a savings over a period of time, and you know what that would be as far as a Medicare savings versus an all-payer growth.
Gary Vogan.
I would suggest that the issue that Mike brought up is better handled by not calling your factor at the end of the PAU table a variable cost factor and confusing it with another program that we have. If you refer to it as a floating neutralization factor or a factor that brings us back to 0.71 or whatever the target is, that is just, it's a mechanical result of having introduced the age adjustment
on a different number, and you're bringing it back to that number, because what was allowed in the CMS waiver isn't the age-adjusted. The age-adjusted number makes better sense in terms of equitably distributing what you have available across hospitals, but I think it would connect better for hospitals to have that be referred to as a variable factor that brings it back to that total, as opposed to calling it a variable cost factor, which then brings up the issue of volumes and fixed and variable costs.
It is currently a variable cost factor. It's not a semantics. What we envisioned, if you look at the update factor tables where we compare global budget versus other, the idea was to apply the 50-50% variable cost factor equally between non-global and global budgets, and then give additional revenues in terms of the infrastructure support to the global hospitals. I think the discussion here is whether you buy into that argument and do 50-50 variable cost factor adjustment on this expected volume, or you go to an approach where you scale the calculated percentages down to the statewide 0.7%.
In that case, I think you're going to have a much longer, more complicated discussion to get people to buy the variable cost factor than you would by saying, we've got 0.71 available, we're going to distribute 0.71, here's the factor that's needed to do that. So I suggest that as an easier way for most hospitals to look at this and see that the amount that is being distributed is the amount that was allowed to be distributed, and have the calculations that have gone into the individual distribution made sense, as opposed to the issue of the variable cost factor applying to both global budget people and the volume-related people. And one of the big benefits that I believed, and I think many people believed, of going into the global budget was that you did not deal with that variable cost factor.
I would say, if everyone is on global budget, probably that will be an easier discussion to have. As long as we have some significant revenues outside of the global budget, that 0.71 is kind of distributed overall, not only for the global budgets that we need to keep in mind. And I think we definitely need another meeting, subgroup meeting, to kind of tease out those issues.
That might be easier illustrated by dividing into two subtotals on your sheet of the global budget hospitals when you have the listing and the non-global, and then applying the 0.71 within each and seeing whether the rules that you have within the non-global will produce that number or not. Because that then would allow the people who elected the global budget to see what I think they expected to see in that process.
But the non-global wouldn't produce that number unless you applied the Care First suggestion, which is to change the policy for the non-global revenues to the same population adjustment as the global revenues. But right now it's 1.1 to 1.2. And so it will take up a higher proportion of the population adjustment for non-global revenues. So that's just mechanically how it works with the policies that are now in place.
But even with the non-global, you have the 50% reduction factor to that, right?
No. Right, but the non-global is allowed to generate 1% in 1.0 to 1.2 if it's in a high growth area. So it will be higher. There's a higher volume growth that's attributable to that could be attributable to the non-global. Yes. So we would have to account for that, but we're hoping, Gary, for the good of getting folks on global.
Another thing, Gary, dollars are fungible, so it depends on how you want to distribute the dollars. If we give out more for these types of volumes adjustments, that's less than that we have to give out for some other type of adjustment, such as infrastructure. Okay, so to the extent that we can provide this amount, which we think reasonably would cover the added expense for the population growth that should occur, then that allows us to provide hospitals with some additional money possibly to actually invest in the infrastructure that's going to be needed to actually treat that population in a more efficient manner. So it depends on how you want to give the dollars out.
This is all very complicated, and I meet myself coming and going all the time when I'm asking questions about these things. But I think the principle of allowing the money to follow the people makes it important to let this factor stand on its own and show that, in fact, the money is following the people in terms of the population adjustment, and make the other adjustments that are necessary on the other side. And I'll recognize that you guys are wrestling with it, and you're going to be presenting it with your thought process. I'll be happy to be involved, and I understand that I needn't be in everything.
Gary, appreciate that. Are there other questions or comments? Well, we're over budget by 15 minutes, but we'll call the meeting adjourned.